A very good morning to everyone. I hope all of you are doing well today. And thank you for spending your precious time and joining us for today's webinar. I am Major Dr. Sanggari, Anak Perempuan Murugesu from Hospital Angkatan Tentera Tuanku Bizan, and I will be serving as your moderator today. This course is a part of an annual event run by our Obstetric and Gynecology Services of Malaysian Armed Forces Health Service to ensure that our doctors can provide good healthcare for all women within our community. So before we start our event, let us go through the tentative for today's event. So today's tentative will start from keynote speech by Head of Services course speaker by Brigadier General Dr. David Shelby. And then today's first topic is approach to the evaluation and treatment of the subfertility couple. Will be given by Colonel Dr. Che Hasnura binti Che Hassan. And then we'll go on with our next topic, hypertension in emergency. This topic will be given by Lieutenant Colonel Dr. Rustini binti Jenal. And then again, another topic by Dr. Che Hasnura, abnormal uterine bleeding. Then at 11 o'clock until 11:15, we'll go for a short break. I hope all of y'all will take your break and will be back on time. And then 11:15, we will continue our webinar with with our next topic is regarding endometriosis. Will be given by Lieutenant Colonel Dr. Nur Azima binti Zakaria. And then about contraception. The following topic is about contraception. Will be given by Lieutenant Colonel Dr. Rustini binti Zainal. And then our next topic will be regarding VTE prophylaxis. Will be given by Lieutenant Colonel Dr. Nur Azima binti Zakaria. And we'll go for our second break at 1:30 to 1:45. I hope you all can grab your quick lunch and we'll be back to continue our session. Then our final topic is from Colonel Dr. Muhammad Farid bin Muhammad Yusof. The topic is regarding mental health issue during and after pregnancy. And then we will end our session hopefully by 2:35 today. So before we start our webinar today, just a little housekeeping. The first one is, if you have any questions during the presentation, please type them into the chat box in the YouTube channel. We have our team to collect all your interesting questions, and I'll bring them up during the question and answer session at the end of each presentation. So you can type the question at the chat box end of each presentation. No need to wait until the end of session. And then you can also WhatsApp the question directly to my personal number. And please write your name at the end of your text. And the next one is, please don't forget to scan your MMA QR code to get your 12 CPD points. The QR code will be given tomorrow, starting from the break session until the end of the webinar. Kindly, if you have any trouble with the QR code, kindly contact Colonel Dr. Shazni. And as a part of Obstetric and Gynecology Services effort to provide you with a timely topic and interesting speakers today, we'll appreciate if you would fill out the feedback form that will be provided at the end of this webinar to get your e-certificate. Now, without further ado, it is an honor to invite Brigadier General Datuk Dr. Tawachelvi Anak Perempuan S. Tanggaraja, Head of Obstetric and Gynecology Services of the Malaysian Armed Forces Healthcare Service, to deliver the keynote speech for this webinar today.
Thank you, Madam Moderator. A very good morning to all the participants who are attending today. It gives me great pleasure to welcome you to the ONG webinar, which is today and tomorrow. Taking care of women's health is undeniably an integral part of wholesome medical practice. Women's health, especially maternal health, has been internationally for the past few decades been used as one of the denominator of good healthcare provision for a designated country. It is essential that healthcare practitioners ensure that their knowledge and skill in this field is always updated. Good healthcare should not only be delivered to military personnel within our service, but also to the female spouses and their family members. Given that the unique nature of military deployment and placement often brings us leaving our clinical practice briefly to serve non-clinical duties, this sometimes poses a challenge to ensure that our doctors are equipped with adequate knowledge, skills, especially in those who are more peripheral military camps and posts. This webinar especially targets the medical officers and to some degrees the nursing staff serving the Armed Forces of Malaysia to update their knowledge in obstetrics and gynecological conditions that they may encounter. I hope that more people will be able to participate as previously, since we are using online platform for current webinar. I ideally hope this includes those in the more peripheral military camps within the Armed Forces of Malaysia. The course coordinator has compiled a comprehensive webinar with relevant topics for your day-to-day practice. Women's health matters. It is only natural that we must provide the best care for the ladies within our community, and we must do it well. I hope you will find this webinar enjoyable, fruitful, and beneficial for your day-to-day practice. That I thank you and welcome to this ONG webinar.
Thank you, Brigadier General Datuk Dr. Chelvi, for the soulful keynote speech. I hope all our participants today will keep at heart her good reminders. So today, without wasting our time, now I would move on to our next session. Our first topic today is approach to the evaluation and treatment of the subfertility couple. This topic will be given by Colonel Dr. Hasnoura binti Cik Hassan. She's our ONG specialist currently servicing in Hospital Tuanku Mizan, and she's with us for a very long time. I hope all of y'all will enjoy her topic today. Without wasting the time, I would like to invite Dr. Cik Hasnoura to deliver her topic. Thank you.
Thank you, Sanggari, as our moderator today. Assalamualaikum and a very good morning. I'm Dr. Cik Hasnoura binti Cik Hassan, one of the obstetrician and gynecologists in Hat Tuanku Mizan. And today I have the opportunity to speak to you guys on my favorite topic in gynecology, which is infertility. Before that, can you hear me well, or do I need to increase my volume? Sangari, is it okay?
Yes, ma'am, I can hear you well, ma'am.
Okay, all right, thank you. So we're talking about infertility. I mean, the first part of getting pregnant, before you get pregnant, I mean, you're trying to conceive first. And this is where I think your method of approaching couples with infertility is very, very vital in obstetrics and gynecology. Okay, from the WHO definition of infertility, of course, we all know that we consider a couple to be infertile whenever they have failure to achieve a clinical pregnancy after 12 months of unprotected sexual intercourse. We can further divide into either primary or secondary infertility. For those primary infertility are those couples who are unable to become pregnant at all, even after trying hard to get one. And the secondary infertility are those who are already pregnant before, or but ended up with a miscarriage or an ectopic, and then later on difficult to get pregnant again, even with or without any pathology behind. So when actually we need to investigate this couple, by right, whenever a couple who just got married for less than a year, I mean, we have to tell them to be a little bit patient, because about 85% will only get pregnant after a year of marriage. And this will further increase after 2 years of marriage. So the cumulative pregnancy rate after 2 years of marriage will increase up to 93 to 95%. But only 50% of couple failing to conceive during the first year will conceive in the second year. That is why we only start to investigate after a first year of marriage without any conception. Okay, but having said that, not all couples should be treated the same. For those who are already known to have some gynecological problems like endometriosis, polycystic ovarian syndrome, those who had an operation done before, or those who had multiple medical illnesses before, then we should investigate them earlier. This, having said this, earlier means not within a month of they get married. Usually we still allow about 6 months of trying actively before we subject them to any form of investigation. And of course, those ladies catching up with their age limit of 35, whereby your fecundity or your fertility potential will be declined or will be reduced dramatically after 35 years of age. Whenever you assess the couple, you have to assess first the dynamic of them as a couple. You know, whenever they come to visit you in the clinic, one, they have to come together. If you see a patient, a lady who comes regularly for checkup without the husband being even one time with them for infertility treatment, that is not a good sign. Okay, you must assess both together, and both must be in the same what we call wavelength to get a baby. You know, not one wanted more than the other. That will not happen. So assessment, importantly, you have the whole thing will start with a proper history, physical examination, and also you have to assess the mental aspect of this couple, because sometimes this fertility issue will be subjected or be shown as a depression, anxiety. You can catch a lot of other diseases or condition that is related to infertility. And at the first visit also, counseling is very important, because expectation of couples different from one to another. Some couple wanted to get pregnant there and then. Some will want to wait and investigate thoroughly first. So you have to counsel them to make sure they understand what they're going to expect from the whole fertility treatment. Investigation, you should tailor it to your assessment. should not be doing everything at spinal cord level. There must be some thinking should be going before you start to investigate this infertile couple. And of course, like I said, the treatment should be tailored accordingly, and no one size fit every couple. Important assessment for both genders. Family history is very important, because sometimes you can detect family history, not to say that if everybody is infertile, then you must be wondering why they are infertile, especially all the male siblings are infertile. They might be having some congenital diseases like congenital absence of vas deferens. That's why they are unable to produce sperm. And then those with recurrent miscarriages before. The most important for female, actually the age, okay, because we are born with certain number of follicles. So when you reach puberty, almost half is gone, and then we are dealing with another half of our pool of follicles. So after 35, this pool are dramatically reduced. So you have to work faster and harder to get them pregnant. In female, if you know the AMH level or the ovarian reserve, that would be great. Any ovulation disorder like polycystic ovarian syndrome or anything, an ovulatory cycle, this is important, because then you know that they are not ovulating monthly to make them pregnant. Certain gynecological condition like endometriosis is a very serious condition in which this will usually leads to infertility if it's not tackled earlier on. If there's any family or family history of premature ovarian failure, it might be also in the case of your patient, so that the history should not be missed up. And PID are oftenly missed because most of the ladies will just discard their per vaginal discharge as a normal discharge, but sometimes you have to dig further to get a proper history, because if it's a recurrent thing, if it's too heavy, too smelly, too copious, I mean, you have to further investigate either there's any element of PID. Of course, those with chronic pelvic pain, those with dyspareunia and all that, then it will also means that they have some degree of PID. For male, of course, you need to know if they are married before. Same goes with female, because especially male, because if they married before and they are able to have offspring, that means most likely it's not a male factor fertility. Okay. Further history of any trauma, any infection, any cancer, any operation done, especially at the genital area, would be very helpful in in targeting what is the possible diagnosis of the male fertility. And also any environmental or occupational hazard, like army is actually one of the occupational hazard. Bomber, all the uniform guys, sometimes they have a lot of training. They are not taking care of the genital parts. The temperature wise correctly. And then of course with the occupation comes smoking, and sometimes in the military or the police, it's difficult for them not to smoke because it's just a culture. So sometimes cigarette smoking, vaping, drugs and all that are contributing to their the sperm production. Okay, from your physical examination, you can get as much as information that you should get, especially the BMI. BMI, obesity will then affect your fertility in many ways. And of course, you can detect a person of polycystic ovarian if you do a proper the Ferriman-Galloway chart for hirsutism. And then if you find that the patient have egalectoria, they might be having hyperproteinemia. Pelvic masses, if it's present, that means you have to further dig out their menstrual history properly, because they might be having a long-standing problem that that needs to be addressed before infertility issue lah. So of course, from this physical examination, and don't forget to examine the male too, you know, especially to know either they are having hypospadias, and then either they are having testis lah overall. Kadang-kadang tak ada testis pun. Ada orang di mana they have undescended testis but was not diagnosed before until they come for infertility treatment. So first, there's a testis or not. Number two, the size of the testis. Okay, size will then show you either this is actually an anatomical problem or like obstruction, or it is actually a production problem. Okay. Okay, so now we go for investigation that should be tailored accordingly. We usually see referrals in which everything under the sun has been done for the patient. Like they come for fertility only one year, but they have all the investigation, including HSG, all done before they come to us. Well, sometimes it might not be necessary, especially for those who have no high-risk behavior like multiple sexual partners, those are not smoking, and sometimes we just see them first, and then we see either the chances of pregnancy too. Is it because of tubal factor? Not tubal factor. Not everybody needs the HSG at the first hand, unless you're thinking the line of tubal blockage. Okay, so the first foremost important investigation is actually the male. Okay, before you start investigating the female, the male needs to be checked first. I mean, their sperm, the semen analysis is very, very important. But it is oftenly not done because the guys will always give excuses of banyak kerja, but no, you don't start investigating the female unless the male factor has been ruled out. So normal WHO semen analysis, the semen volume should be 1.5 mils or more. The semen volume is not equal to the sperm volume. Okay, semen is actually the cecair, right? The cecair is actually produced by the prostate. Okay, just to show it's either it's a healthy or genital organ ke tidak. Okay, so the semen volume of more than 1.5 will only give the actual sperm volume per ejaculation. Okay, so pH must be 7.2 or more. The sperm count that we are taking now, this is 2010 WHO reference value for semen analysis, which is what we are using now, must be more than 15 million. And total motility, we always look at the progressive motility, which is 32%, and the vitality 58%. Sperm morphology is very, very important. This is the one that will determine either you're gonna get a poor DNA, poor embryo, end up with a miscarriage and all that. It must be more than 4%. We just need 4%, okay? Not more than that, and not less than that. If less than that, there might be a problem in conceiving, in sustaining the pregnancy also. So sperm develop and being produced in the testis, and then it will stay in the testis up and then waiting to be ejaculated. So they will travel to epididymis during ejaculation time, it will come up. So if the sexual intercourse is not that frequent, I mean, if it's the frequent one, we say 2 to 3 times per week. If it's not that frequent, then those that travel to the epididymis might die off. So sometimes this happen. When this happen, you do the semen analysis, you see a very poor product. Not because it's really representative of the actual pool in the testis, but because of the accumulation of the old or non-used sperm that is being accumulated throughout the weeks or days that they haven't had sexual intercourse. Okay, so that is important before you read any semen analysis to know when is the last sexual intercourse. It must be 2 to 5 days sahaja. Tak boleh lebih daripada 5 hari, tak boleh kurang pada 2 hari, because then the result will not be accurate. And this is the morphology that is being seen from the semen analysis. The normal form is a good head shape and a good neck and tail. the DNA is being carried by neck. Okay, so if there's a neck problem, more than the other problems, that means you know that you're going to end up with a not a good embryo and even a miscarriage. Vasogram is rarely done. This is to see obstruction. It's not done routinely, only if those cases that we are, quite kind of confused when we do PESA, there's nothing. So then we thought it might be some, ejaculatory duct problem. Then we do this vasogram. But seriously talking, I never seen one before. Then we go move forward to the ladies' side. So how you assess the ladies' ovulation? Of course, by the menstrual cycle first. Those who are having regular cycle should be having a normal ovulation. Should, bukan must, bukan wajib. Sometimes they don't ovulate, but they have a normal cycle. Okay. So day 21 serum progesterone is the marker that we look for lah. So if it's more than 30, that shows that the lady is ovulating. Why day 21? Because this is only accurate for those who are having regular cycle or 24 to 34 days. Okay, for those who are not having regular cycle, you have to do the 20-day serum progesterone 7 days before the next cycle. But it's a bit difficult because you don't know when is the next cycle. Okay? So whatever it is, it must be done in mid-luteal phase. Anything lesser than that, that means that the lady needs help in stimulating the follicles to grow and ovulate later. Then you can also do an LH search on the urinary just to see either before ovulation, you're going to have LH search. Okay, your hormone will then increase, the LH hormone will then be high. Then you can detect it in your urine. If it's positive, that means within 12 to 16 hours later, ovulation might occur, and then it will stay for almost like 48 hours in your body. I mean, the egg, the oocyte, if it's ovulation occur, the oocyte will stay within like 48 hours in your body. That's why it's a very short period for you to know either they're ovulating or not, so that the oocyte will not be wasted. And then you need to assess the ovarian reserve. So who do we need to know this? Okay, for those who are more than 35, so you don't see a point of stimulating patients with such a high dose of medication if they are not having a good reserve. Nothing to be stimulated. So nak bagi ubat apa kan? Why you want to stimulate? Waste of money. So for those who are aged over 35, they deserve an assessment to see the ovarian reserve. Those with an unexplained infertility, like for more than 15 years, without any clue of why they are infertile, they need to know what is their ovarian reserve. Those who with family history of early menopause, those with ovarian surgery, radiotherapy or chemo, and those who we have stimulated for IVF or IUI with such a high dosage of gonadotropins but unable to respond well. So how do we assess? The one that is available in our hospital, in our setup in ATM, is this day 2 FSH LH estradiol. We don't do this much for PCOS anymore, okay? So we don't see the LH FSH differences for PCOS because that is not required in the diagnosis of PCOS anymore. So we do this to see either they have diminished or normal ovarian reserve. So if it's more than 20 FSH at day 2, that means the ovarian reserve is poor. And they might be not responding to any of your, maybe a poor responder to your gonadotropin stimulation. And if it's the day 2 estradiol is less than 50, then it's less than 50 is normal. If it's more than 60, then that means they are already in the aging processes. I mean, they are, we are talking about early follicular phase in day 2, not overall. So kalau day 2 is already high, that means their reserve is depleting. So in other words, if you are doing this test as a routine, so you need to know the value ni apa maksud dia. If we FSH, LH low, apa maksud dia? If it's elevated, what does it mean? Normal, and how would you tailor it or refer it accordingly? If it's low, that means they have some hypogonadotrophic, hypogonadotrophic, hypogonadism. So that means everything is low. So they are at the group 1 of this problem lah. So if FSH is normal or LH elevated, but E2 is normal. This is in the case of polycystic ovarian. Okay, so they have the hypothalamic pituitary dysfunction. Then if it's low, it's elevated, estrogen is low, of course, obviously this is the group 3 or in cases of premature menopause. Then the most important one now, especially for fertility specialists, is the anti-Mullerian hormone. Anti-Mullerian hormone is not done in our hospital, but we can do it in private center, costing about 150 to 250, depending on which center. It can be done at any time of the cycle. If it's a low reserve, there's a chart according to age. Okay, if it's low, then you know that you don't give high stimulation because they will not respond that well. If in high reserve, in cases like polycystic ovarian syndrome, then you need to tailor your stimulation accordingly. You have to start with a very low dose and step up accordingly. And we can also do total antral follicle. This is done at day 2 of menses in our gynecological setting, just to see either they are having low AFC or high AFC. Because why? Because if there's high AFC, like more than 10 follicles from the scan, you know that this patient might be having polycystic ovarian syndrome. Then, of course, from the scan also, you have to assess normal anatomy of the uterus and the surrounding by doing either trans-abdominal or transvaginal scan. Transvaginal scan will offer you more information rather than trans-abdominal scan. If you can do it, try to do it. See the normal first, and then you can identify the abnormal ones. And then we have to assess the tubal patency if it is indicated lah. So tubal factors is 14% of the cases, in cases whereby there's a pelvic adhesion from either surgeries, like those patients with pernah ada operation for appendicitis or any acute abdomen, they might have this pelvic adhesion that leads to tubal disease or tubal blockage, and endometriosis also. And then the common test that can be done is either HSG, or if there's any other factors that renders them to do a laparoscopy, we straight away do laparoscopy dye test. HSG is only about 65% sensitivity. That means true positive is detected in 65% and miss in other 25%. It is usually carried out in the first 10 days of menstrual cycle. Why? If there's any if there's any pregnancy and do it if patient already pregnant and you do it later, it might disrupt the pregnancy. And also, it may also leads to a flare-up of PID if patient is at high risk. That's why your history of PID is very important. If there is any element that may be suggestive of PID, you better give them some antibiotic prior to the investigation. And then lab and dye test will give more information in terms of the uterus, the tubes, the ovary. Sometimes ovary is too high because of adhesion. The tubes are actually stuck to the lateral pelvic wall because of adhesion. Then in the same time, we can do electrolysis and treat the condition, okay? But it's not recommended as a first line of screening test. Those who have a history suggestive of endometriosis and PID, this might be beneficial. Then you have to assess the uterine cavity. Why? Because sperm has to go through the uterine cavity before it reaches the fallopian tube. We do a thing called high COSI or saline infusion. High COSI is using a specific contrast. For saline infusion, we just use saline, in which you can see the uterine cavity more prominent, and then we can see either there's any feeling abnormality or not. This is any anything that suggestive of any obstruction like submucosal leiomyoma. Okay, so whenever you have any findings from your assessment history of physical examination, then you straight away do this. If there's any something suggestive that maybe some ovarian reserve or ovarian problem, then you straight away do your FSH, LH, and then you do your MH, okay? And if it's a fibroid that you detect, a submucosal fibroid you detect, then you straight away do hysteroscopy just to confirm at how big, at which area, either the osteum or the block or not, okay? And thyroid function test, of course, you only do it if clinically it is suggestive. Okay, there's any sign of hypothyroidism, you do your TSH. TSH is normal, we take up to about 4. If more than 4.2, usually it might impact fertility chances. So we do TSH sahaja. We don't do T4, TSH or the whole thyroid function test. From the TSH, then you can guide you whether you need to do either things or not. Okay, why TSH increase leads to infertility? Because somehow it has because everything is actually FSH, LH are all produced by the same area, by the TSH. So once it is actually increased, then the thyroid might then reduce plasma binding. The TSH might reduce the plasma binding of the sexual hormone binding globulin, and then make it an increase unbound total testosterone and estrogen. This would leads to imbalance of the hormones, that leads to problem in ovulation and all that. It also increases thyroid releasing hormone, whereby it also stimulate the serum prolactin increase. So bila prolactin is high, then it impedes the ovulation. Prolactin, the normal one, reach less than 40. Prolactin, however, you do it even though they have no symptoms. Because why? Because most of them are asymptomatic unless it's in the thousands in cases of pituitary adenoma. But the rest are usually just about 500, 600. We usually treat if the level of prolactin is more than 400, okay? How does it affect fertility? It interferes with the prostata secretion of GnRH, impairs the FSH, LH secretion, and of course, then it reduces the estradiol concentration. Okay, let's move on to causes of infertility. Just whiz through to the causes that may lead to fertility. We have female, male, and combined factors. Of course, you don't blame the female all the time, because 30% is also contributed by the male, and also sometimes it's a combined factors. Okay, so causes of male infertility, there are many. This is the most worrying one, because if it's a primary testicular disease, nothing much can be done, because it's actually the production is totally impaired. Okay, so this man requires a karyotyping before any infertility treatment. Obstructive cause, there's a hope at the end of the line, because obstruction can occur at any level. If it's at the level of epididymis, or then we can do an aspiration, and then it will then still can be used for IUI or IVF. Okay, but if it's at the red testis, which is at the testis level, that way we can only get a sperm from the biopsy of the testis. That will be a little bit difficult. So this is the procedure that we do. PESA is the aspiration at the epididymis, and then TESA, aspiration at the testis, or we must remove an area of the testis just for us to see if there's any sperm, immotile sperm. Because if you get it from the testis, the sperm most of the time is not motile. Okay, testicular biopsy is not done regularly. It's only during the diagnostic TESA that we don't find any mobile sperm, that we do to see the Johnson score. Johnson score is to see at which level of production that the sperm is at the testis itself. If it is actually number 5 and below, that means the chances of fertility is almost like less than 1%, very, very low. Because in Malaysia, we don't do spermatids IVF. We're using spermatic, the immature one. We only use spermatocytes for it. And then some endocrine disorders like thyroid, prolactin also can be occurring in men, so they can also lead to some degree of impotence, and of course will have some not so much effect on the sperm production. Autoimmune disorder, 12% of the couples, actually the husband having some anti-sperm antibodies in which they decrease the sperm motility. This is actually not routinely done, even in the IVF centers. Only if there's any suspicion, then they're going to do this test. And other drugs that may impact motility, production, this includes alcohol, cigarettes, vaping, opiates, and marijuana, and other anabolic steroids drug, corticosteroid, and chemotherapy. This might lead to causes of male infertility. Environmental factors are mainly due to heat, and of course any ionizing radiation. So this group of patients, we have to dig further on their exposure to other radiation, heat, X-ray, mercury, anesthetic gas, but somehow we don't see much anesthetists that is actually infertile. So, but in army, azoospermia is quite prominent for those who come to our clinic. So, but either it is a direct correlation, we don't think so. But those who come with infertility, one of the risks for the male that come with it is actually azoospermia. Varicocele is a blockage, so it obstruct the normal flow. This one can be corrected, but however, post-varicocele conception is still a little bit low. Then some with ejaculatory disorders, for those who are diabetes or neurological disorders, may then come to you with some problem with ejaculation. And then we go to female infertility. The main one would still be endometriosis infertility, tubal infertility, endometriosis, uterine, and of course, for the couple, unexplained infertility. Okay, for the factors, you can see ovarian dysfunction plays the major role of infertility in ladies. So what is this endometriosis infertility? For those group 1 are actually amenorrheic. They are hypogonadotrophic hypogonadism. It is characterized by, like I said before, low FSH, LH, and low estrogen level. Accounts for about 10% of ovulatory disorders. It can due to either iatrogenic or it's actually genetic. So iatrogenic, if patient had previous history, this could also be the secondary infertility. So if patient had previous history of PPH, okay, that is an important history because PPH, a severe one, can lead to Sheehan syndrome that leads to amenorrhea and infertility. Okay, those who are having TB, pelvic TB, they can also lead to this problem, and those with condition like Kalman's, Prader-Willi, might also come up with this hypogonadotrophic hypogonadism. Iatrogenic also sometimes, not iatrogenic, I mean acquired causes are like those who are suddenly doing excessive exercise or psychological stress or having anorexia nervosa. This will then impact the secretion of GnRH that leads to a temporary condition of this problem. So it's actually reversible if it's addressed at the earlier on. Don't wait too long to manage like anorexia and all this, because it will then eventually it will then just fall off and they will not be able to reverse the condition. For group 2, this is hypothalamic pituitary dysfunction. Like I said earlier, LH is high, normal estrogen. Okay, sometimes FSH is normal. It accounts for 85% of ovulatory disorders. Predominantly, like everybody knows, it's about polycystic ovarian syndrome. Since polycystic ovarian syndrome, why we call it a syndrome, not a disease? Because it's actually a collection of condition or criteria that we need to fulfill before we label a person polycystic ovarian syndrome. Do not, I repeat, do not label everybody with irregular menses and obesity with polycystic ovarian syndrome. Okay, the obesity, poor diet, physical inactivity does lead to some hyperinsulinemia that leads to high androgen production. But there are other factors also that play a role that leads to this condition. That's why you can see sometimes there are lean polycystic ovarian, and there's also obese polycystic ovarian. Okay, so how do you diagnose this polycystic ovarian syndrome? There are a lot of criteria being addressed, but those most of us are using the Rotterdam criteria, in which Rotterdam you need 2 out of 3 to, and after exclusion of other etiologies, baru you diagnose them with polycystic ovarian syndrome. So what are these 3 criteria? Oligo, and ovulation. So it does not mean that an ovulation sahaja. Oligomenorrhea means that the cycles interval is longer. The normal cycle, I hope you guys know, is about 24, 34. But if it's more than 35, ding ding, you have to think that might be an oligomenorrhea. Okay. And then number 2 is hyperandrogenism, either clinical or biochemical. We don't use FSH, LH anymore. Okay. So we use this hyperandrogenism. If the blood investigation doesn't show anything, if they have signs that hyperhidrotism is positive, acne, acanthosis nigricans, then they are actually positive for hyperandrogenism. And the last one will be polycystic ovaries from the ultrasound features. It must be measured. The ovary must be measured because sometimes dia punya follicles tak banyak, tetapi dia punya ovarian volume is more than 10 cc. So they still fit in the criteria of polycystic ovaries. So this 10 cc macam mana nak dapat? You have to measure in 3 dimensions. Okay. So of course everybody knows they come, if the obese PCOS, it's an obvious signs. You can see them from far away. Even sometimes in the bad thing about us gynecologists, sometimes in the restaurant also we see somebody with she's polycystic. No, that's not nice, but we do that because it is so markedly prominent if you're having the actual obese polycystic ovaries, because sometimes the hairiness can show you can see that the foramen Galloway is more than 18. Okay, so the last one will be the group 3 is ovarian failure. Results of the ovary to respond to the gonadotrophic stimulation. This happened about 5% of the ovulatory disorders. Mainly, we label them as premature ovarian failure. Then we have tubal infertility. Tubal damage can be due to many factors, PID, one of it. And of course, there are rare causes like Crohn's disease. And of course, iatrogenic from tubal ligation or pelvic surgery. Endometriosis can affect fertility in many ways. This is even one topic of essay questions for master's students. Yeah, endometriosis, how does it affect infertility? So I'm just giving you an outline. It reduces the oocyte quality, reduces uterine mobility, and also some tubal damage can be done by endometriosis that leads to impaired peristalsis of the tubes. Uterine factors, submucous fibroid, does it affect fertility? Yes, if it is submucous one. Subserosal, you can leave it. Even it's huge, you can just leave it, you know. But submucosal, if it's more than 3, sometimes we do operation just to remove it, just to increase the fertility chance. Of course, other factors like congenital abnormalities, intrauterine addition like Asherman syndrome, endometritis recurrently might lead to infertility. Okay, in the 15% of the cases, you don't know, you can't find, you can't point out a single factor that leads to their fertility. You know, this is the unfortunate one, and this is actually the most frustrating one because the explanation might be lengthy, but the depending on the acceptance of the couples, some will be okay, but most will be confused why they are not conceiving. But in the end of the day, this is still a gift from God. So that's how we usually explain. But this group of people, when you stimulate and you do treatment, they responded very well. So management, as an overview, if it's more than 2 years, you have to do something, you know. You have to offer something. Either they're AMH normal, scope apa tu dia punya tu normal, we start with IUI if it's a few times IVF. In certain centers like UK, after 2 years, then straight away to IVF rather than IUI. Okay. But if it's if there's any problem along the line with any problems like you are suspecting poor responders or poor ovarian reserve, then IVF. Dysmenorrhea, PID, you do laparoscopy first, and then laparoscopy first just to establish the diagnosis, to confirm the diagnosis. But sometimes if you are going for fertility treatment, those with endometriosis, cysts semua tu, you can hold after the stimulation of the ovary, because sometimes you can deplete the ovarian reserve by doing operation before infertility treatment. Lifestyle modification helps a lot, especially in polycystic ovarian syndrome. By reducing their weight by about 10% saja, you improve the ovulation about 50 to 60%. Avoid tight and warm undergarments, especially for male lah ni kan, but it's difficult. But what you can do, especially with their job scope, like in the army, in the firemen, police, all the uniform men. But sometimes you just tell them when you go back at home, you just release everything, you know, you don't have to even wear anything at home lah, like that. So because it will just improve the overall temperature at that area. Quit smoking, difficult but needed. If they are serious enough to get pregnant, they should be serious enough to quit smoking. That's about it. Sometimes if they don't want, they need the ding dong, quit ke tak quit, that means they're not serious enough, okay? So of course, no drug, alcohol, stop immediately, okay? And then frequency of intercourse. With the current what we call that current era of everybody is working, everybody is so busy and all that. Even teachers are complaining they are not having sexual intercourse regularly because they are so busy at work. So efforts, you just have to make effort, because this is what you want to get pregnant, you need to increase your intercourse interval, okay? Any problem with endocrine disorders, you have to manage, ideally with the medical team. And sometimes, you know, azoospermia that is caused by some endocrine disorders, you can treat prior to doing diagnostic PESA or TESA, so that we can get a good sample of sperm. Obstructive azoospermia, we can use the PESA TESA to get the sperm and then to use it for IUI or IVF. In some centers, like in US, in some urology center, they even correct the block to facilitate the passage. However, by doing this, it doesn't increase the fertility success. So that's why we are moving towards the PESA TESA rather than correcting the block. In ejaculatory failure, this is not an issue that much, because if it has retrograde ejaculation, that means rather than the semen goes through the penile, during the penile thrust, they ejaculate into the urine. So what we're going to do is we can clean up the urine and take the sperm and use it for IUI. So we can do that, okay? So there is not a big issue. Varicocele repair, but repair success rate, pregnancy after repair are not that great. Then for the ladies with end ovulation, okay? So ovulation induction by medication is the main thing after your weight reduction, lifestyle modification. So we use either Clomid or tamoxifen, or we can also use Femara. And then gonadotropin reducing hormone analogs like FSH, LH and all that. Just an overview how Clomid and also aromatase inhibitors work. Aromatase inhibitors can be letrozole and could be also be tamoxifen. However, we usually use more of letrozole rather than tamoxifen. Tubal factors, tubal surgery is indicated if there is a perifimbrial adhesion. Maksudnya, dia ada previous surgery, the tube, the fimbrial is actually adhered, so we can release it. But those with the total blockage of the fallopian tube, there's nothing much that we can do. If a proximal occlusion, we can still do hysteroscopic tubal cannulation. We put in a tube, hysteroscopically and then release the blockage at the proximal tube. Uterine factors, if it's a myoma, you do myomac, septate, you do hysteroscopic metroplasty, intrauterine addition, you do adductolysis hysteroscopically. This is actually Asherman. And then you put in IUCD, and then after that, you stimulate them for pregnancy and remove the IUCD. Endometriosis is a challenge to manage. I think Azima will talk in length during her session. But we have medical and surgical management. For fertility-wise, we usually try to avoid surgical first, unless it is unavoidable. Ovarian drilling for polycystic ovarian syndrome will only be subjected if we wanted to see other things also, like the tube. Okay, patient come, we don't know the tube function, polycystic so dramatically prominent, so we offer them ovarian drilling during the same time to see the tube for dye test, or if there's any cyst to be assessed, or suspicious cyst to be assessed, then we offer them ovarian drilling. The rule of 4 for ovarian drilling, for minimum of 4 puncture, 4 millimeter, and for 40 hertz and 4 seconds. Yeah, so that we don't destroy the overall pool of the tissue. Then, of course, after settling out all the other factors, then we offer them some assisted reproductive technique. The simplest one would be intrauterine insemination. Intrauterine insemination, in which patient that will be useful? Of course, those with no tubal factor lah. Janganlah buat kat orang yang ada tubal factor. Kalau tubal blockage, tak boleh buat IUI. Because why? Nak lalu mana kan sperm tu, so cannot. So we like to offer intrauterine insemination, one, for those unexplained infertility, because they will have tremendous response towards IUI. About 10 to 50% saja chances of success, and those who sperm is quite lazy, like those with astenospermia, then they might be good to be subjected to intrauterine insemination. Then we also have assisted reproductive technology yang lagi advanced, especially for those with severe infertility issue. Of course, those who are subfertile or infertile for such a long time, then we offer them IVF of ICSI. IVF and ICSI both are actually in ART. The difference is IVF is whereby we let the sperm pool to decide whoever is the best among them to penetrate the oocyte, while ICSI, we the embryologists choose the best sperm and inject it one by one to the ovary, to the oocyte, sorry. And then after a while, then you see either there's any embryo development or not, and then later on transfer for baby. Okay, I think that's all from me as an overall view of infertility. And the most important one, okay, infertility, subfertility, the term is being used interchangeably. So infertility for us is usually never conceived at all. Subfertility sometimes we use for those who had pregnancy but did not carry forward lah. But you can just use it interchangeably, no problem. Okay, it's like diversion or diversion. Kan, diversion is US, diversion is itulah. So it's just a similar thing. And then for me, just to emphasize it, just for you to assess properly, and then investigation, and then send it to the fertility specialist accordingly. You don't send patient for those who need IVF, tak payahlah send to normal gynecologists. I mean the general gynecologists, because you know they don't have that the facility to get situ. So straight away send them to center that can do IVF. Okay. With that, I thank you. A question, if any.
Thank you, ma'am, for the informative and interesting talk. Now we'll move on to Q&A session. We have few interesting questions, ma'am. The first one is from Major Dr. Zariman. why armed forces don't have their own IVF center? Then how couples from outside Klang Valley, ma'am, especially from Sabah and Sarawak, to get their referral for their fertility treatment? That's the first question, ma'am.
Okay.
Then,
I answer straight lah dulu.
okay. Yes, ma'am.
Thank you, Aiman, for that question. The stakeholder in ATM is our soldiers lah, kan? So in a way, ONG in armed forces is actually a supportive support unit rather than the main unit. Fertility issue is not really apa tu kita cakap prominent kalau you perasan daripada dulu. Only the last 10 years that this fertility issue has been brought up and subspecialty program has been offered and all that. In the army, slowly but surely we're gonna go there. But it involves a lot of costing, a lot of manpower, a lot kena train embryologists. There are a lot of things that need to be make it available first, training and all that, baru kita boleh buat IVF center sendiri. But we have a good rapport with UKM, HKL. So anybody that needs that, I mean, we can be the pemuda cara for you guys to be referred to these centers. And of course, outside of Klang Valley, the thing about in the armed forces or in any government party sebenarnya, the IVF treatment is not being kita tak cover kan, dia tak 100% being covered. So in a way, how we can help our patients in the ATM for that is to reduce their burden in paying for the medication. Some of the medication that we are already making available in our centers, only if you are under patient in our center, that means in Hat Tuanku Mizan or in other centers who have the medication, then we can offer to you guys freely. Faham tak? If the other patient that has gone through other department or other hospital and they wanted to minta the medication, it's going to be a little bit difficult. So for me, if everybody watching is from periphery, you just refer to me. Sabah Sarawak is a bit difficult, but of course Sabah Sarawak also ramai orang Semenanjung. So refer to me or refer to my colleagues in KL especially for us to make them under our patient and to see whether they are eligible to get the medication. Because sometimes you see ada orang baru 6 bulan dah terus pergi buat IVF treatment while they don't need it. Okay, they straight away want to do IVF sedangkan dia boleh buat IUI. So we will be the one that will be tapis kah benda ni so that which one they should go first. Alright.
Okay, ma'am. Thank you, ma'am. For the second question, it's from Major Dr. Dalila. Does weight reduction help for men to improve their fertility, or it's only for the woman? The obesity issue is only for the woman, or also men, or men also having the same problem due to the obesity issue, ma'am?
Yeah, obesity affects both men and women. Men, if they are obese, the problem that we see often is actually ejaculation problems lah. Ejaculatory problems with obesity is quite prominent, but not much on their production. That means the numbers. The numbers are not affected that much, tetapi the quality, the DNA, and also the morphology. Yes, the morphology are affected because for the morphology to be normal, there are a lot of hormone stimulation that needs to be there and be normal. So with obesity, sometimes they're going to have high testosterone or low testosterone. This will then impact the good quality sperm. That is why for male also, smoking and reduction of weight is also the main thing that we advise.
Ma'am, I think the last question I'll take for the last question, ma'am. This is from one of our house officer, Lieutenant Dr. Hari Krishna. I think he's very curious about this, ma'am. Does douching with baking soda and vinegar help with that gender determination? She wants to know that, ma'am.
I think kalau you for infertile couple, they just want a baby. Doesn't matter, baby girl ke, baby boy ke, they just want a baby, kan? So of these taboos that being done, tengok anak bulan bulan berapa, anak bulan hari bulan berapa. You know, Chinese calendar has hari apa, bulan berapa untuk get boy or girl. None of them are randomized control trial, and none of them are actually scientific papers lah. You want to try, you can try. If it's successful, congratulations, you know. But if it's not successful, don't blame anybody but yourself because you're doing that. Okay? No, it doesn't, because it doesn't have any scientific basis behind it.
Okay, thank you, ma'am, for this very informative and interesting talk today. I hope everybody got to know a clear picture about our fertility services that we provide in our armed forces, and get more, they got enough information to know about the fertility treatment and what to investigations to do. And if there is any referral that you all need to do, feel free to refer to us. And if anyone has more question, I think you all can directly message Dr. Cik Hasnura or just call her to get answer for your questions.
Yeah.
Okay, thanks, ma'am.
Thank you.
So we will take 1 minute break prepare for our next speaker. Our next topic for today's webinar is hypertension in pregnancy. I would like to welcome Lieutenant Colonel Dr. Rustini binti Zainal to deliver this topic to us today.
Right, thank you, Dr. Sanggari. Bismillahirrahmanirrahim. Assalamualaikum and good morning. So my topic today is hypertension in pregnancy, complication and preventions. Okay. Okay. So the introduction, as we know, the prevalence of hypertension in pregnancy in worldwide about 7.7%. So it's very important because, okay, hypertension can cause the complication about 10% to maternal or neonatal morbidity mortality. Okay, in Malaysia, cause of maternal mortality is a fourth cause. Okay, about 6% maternal death in 2020 lah, followed by the first causes is embolism, postpartum hemorrhage, and also cardiovascular events, and also ectopic. That's why we have understood the background of hypertension. We know understood the hypothesis of hypertension, preeclampsia, before we can go through the further management. So table of contents, we have classification, hypothesis, complication, prediction, prevention, and last objective management. Okay, so classification of hypertension disorder pregnancy, we can divide into two groups. Okay, once we diagnose systolic blood pressure more than or equal to 140, or diastolic blood pressure more or equal to 90, okay, she already diagnosed hypertension. But if diagnosed before the 20 weeks, okay, we label as chronic hypertension. Okay, so for the chronic hypertension, later they can develop superimposed preeclampsia. The second group, okay, if the high blood pressure after or at 20 weeks, okay, we class into gestational hypertension or preeclampsia. For the preeclampsia, if involve the target organ involvement. Okay. All right. So chronic hypertension recognized at less than 20 weeks gestation. Okay. Usually we diagnose during the early antenatal booking. Okay. We should confirm by 20 hours BP monitoring, or we repeat the blood pressure over hours, same visit, or we go patient the other 2 consecutive antenatal visit we see. Okay, majority due to essential hypertension. Okay, there's another terms white coat hypertension, high blood pressure at clinic but normal at home. Normal at home, tapi kita not simply take it as a benign conditions, but they still have risk to develop the preeclampsia later. Okay. Gestational hypertension, de novo hypertension that develop at or more than 20 weeks gestation in the absence of features of preeclampsia. 25% later we develop preeclampsia. Later life, okay, we develop chronic hypertension. We go for the preeclampsia. Okay. Before that, we know preeclampsia, high blood pressure with proteinuria, more than 20 weeks gestation. Okay, now our definition already ada sikit perubahan. Okay, gestational hypertension accompanied more or equal to one of the following onset. Okay, one either proteinuria. So proteinuria, you can either you using the urine dipstick more than 1+, or you can send for urine 24 hours, more than 300 milligram per day, or can you use the protein creatinine ratio more than 30 milligram per millimole. Or the patient no proteinuria but involve maternal organ dysfunction such as renal involvement, liver involvement, and increase the LFT SST more than 40, or she has symptoms of upper quadrant or epigastric pain, or neurological complication, eclampsia, severe headache, stroke, okay, or visual photomata, and the other one is hematological complication, okay, low platelet, low hemoglobin, or the IVC. one of the maternal organ dysfunction with high BP, so already classified as the preeclampsia. Another one, uteroplacenta dysfunction. Okay, we can see the fetal growth restriction or abnormal uterine artery Doppler wave or stillbirth. So hypothesis of preeclampsia. So we know the origin, so we can understood the pathway, and then easy to we can develop the prediction, and we can do some prevention for the preeclampsia. Okay, so hypothesis preeclampsia started from all the either genetic factors, immunological factors, or other factors. She already known hypertension, diabetes, obesity. All these factors can cause the abnormal placentation. Okay, so the thromboblastic invasion is very poor, can cause the hypoxia, can cause the placenta ischemic. All right, so they release all their mediators, okay, anti-angiogenic mediators proteins such as PIGF, BEGF, or SPLIT1. Okay, so anti-angiogenic condition can cause the endothelial activation. Okay, we can see the gambar here. All right. Okay, this is non-pregnant. Okay, these are three from the mother. Okay, this is uterus. Okay, we see the normal pregnancy. Okay, and compared with the preeclampsia invasion of the prophylaxis. Okay, all right. Because of the maternal artery, spiral artery is abnormal. All right, so the invasion is reduced. The cytopropylas invasion is reduced, and the release mediators for the other vessel is vasoconstrict compared to the normal pregnancy is vasodilatation. Due to that, all right, the uteroplacenta flow is reduced, right? Can then increase resistance to the maternal blood. What after that, the mother developed the preeclampsia and others complication, such as, all right, mother developed the preeclampsia, hypertension, or later to the cardiovascular, APO, acute pulmonary edema, okay, and then they can affect to the kidney, so develop the proteinuria, or the severest one, acute kidney injury, and also liver can cause a hemorrhage, okay, and HAP syndrome, hemolysis, elevated liver enzyme, and low platelet. How about the baby? Because of placenta hypoperfusion, right, the growth is become IUGR, okay, or is late, can be stillbirth. All right, and the placenta also can be abruptio. There is all the complication for the preeclampsia. Okay, so preeclampsia may never predictable, but better prediction would have to focus on antenatal care effectively. Okay, but there is no good screening test. Okay, still under clinical study, they still evaluate which are the better prediction they can be used. Okay, all right. So our setting, especially in result of PERPAT or MCH, maternal child health clinic, okay, so the early antenatal working, we assess the maternal risk factor. So we can divide either the mother has a high risk or low risk, okay. For example, the high risk maternal risk factors, history of preeclampsia, chronic hypertension, diabetic, okay, anti-phospholipid syndrome, chronic kidney disease, and also they use the assisted reproductive technique. Okay, so ART, okay, pun include the high risk maternal risk factor develop preeclampsia. Okay, low risk such as advanced maternal age, all right, family history of preeclampsia, primate, okay, short duration of sexual relationship, less than 6 months. Okay, why? Because this involve the immunological factor. Okay, sebab dia orang just married and then knowing each other sometimes the husband or the wife also, they develop the antibody. Okay, that's why the short duration sexual relationship less than 6 months also have risk develop the preeclampsia. Primary paternity. Primary maternity next mean the kahwin first union, get the child, and then they remarried the second union. So the second union too, the first child for the second union, so they can develop the risk. Okay, or interval pregnancy more than 10 years and also multiple gestation. Okay, so during the booking, antenatal booking, from that we are also already known, already on the screen or the maternal risk factor. Okay, from that detection rate about 40%. Maternal risk factor alone, we can detect 40% can develop the preeclampsia. Okay, what else we can predict? We use the blood pressure. Okay, blood pressure and also mean arterial pressure. So as we know, blood pressure is a routine surveillance and diagnostic tool. Okay, so diagnosis made if more than systolic more than 140 and or diastolic more than 90. Okay, another we use the mean arterial pressure. So how we calculate it, diastolic blood pressure +1 and divide the systolic blood pressure minus this diastolic darab 3 macam tu. So if you get the mean arterial pressure more than 85 or 90, okay, so it can predict the develop the preeclampsia. So usually during the first trimester, we see the maternal risk factor, which is a high risk group, and also the blood pressure. So maybe we can, it's not maybe, we can give the low dose aspirin. All right, we give the low dose aspirin, or during the second trimester, again, we go through the maternal risk factor, we see the monitor the blood pressure. Okay, so during the second trimester, maybe we can identify group for close surveillance lah. All right, okay, so detection rate, if MAP alone, about 40 to 50%, but it is very specific. But if combine maternal risk factor and also mean MAP, so detection rate about 50 to 60%. Okay, I think this two tools, the maternal risk factor and also MAP, is very good if we can do screening in our center or our setup lah, antenatal checkup. Okay, another tool is biomarkers. All right, it's difficult to do. The test is difficult to do, and not all the hospital or centers do the biomarkers. This is more on clinical study and evaluation. Okay, usually they do the monitor the PAP-A. Okay, so the PAP-A in preeclampsia is reducing. Okay, so the reading during the first trimester, the reading is less than 5 centile. Okay, so the chance untuk develop preeclampsia is there lah. Okay, a few study. Okay, this one more on the second trimester. Okay, the split PIGF ratio and also PIGF. Okay, sorry. Another first trimester biomarkers, okay, the pregnancy outcome of the predation study. So they use the ratio of beta-protein and also part A ratio. Is the ratio more than 10, okay, relative risk develop of preeclampsia is 2.12. Okay, so there are two biomarkers they use during the first trimester, and the second trimester, usually they use either PIGF alone or the ratio of split PIGF ratio. Okay, PIGF, the ratio as split PIGF, this is a prognosis study. Okay, they use less than 34 weeks. Actually, they rule out, they exclude development of preeclampsia. If the ratio is less than 38, all right, so unlikely to develop preeclampsia over the 1 week, within the 1 week. Okay, so the goods here, so kita boleh tahu, okay, unlikely patient develop preeclampsia, so patient boleh monitor as outpatient. Alright, no need the an ICU backup, no need the for steroid for lung maturity. Okay, alright. Okay, PIGF lebih kurang sama dengan the ratio, the Pelican study, but it used less than 37 weeks. Okay, is the reading less than 100, represent developed preeclampsia within the 2 weeks. Okay, because why is important? Sebab kita nak try to reach the baby for lung maturity baby. So if the baby can deliver more than 34 weeks, right? Okay, the prognosis for the baby is good compared if they deliver preterm less than 34 weeks. Okay. The other prediction tools, okay, you can use the uterine artery Doppler, right? So uterine artery Doppler, you can either during the first or second trimester, okay? All right, this is look the normal wave, okay, uterine artery, okay, the peak one is systolic, this one average, and here diastolic, okay? All right, so normal, okay? Okay, if compare the preeclampsia, right? This uterine artery, we do either can use, this is a very technical procedure, either you can use transabdominal, tapi most likely use the transvaginal scan, okay? So you can see the notch, notching at the umbilical arteries, okay? Alright, this. Okay, kalau anda nampak, obviously lah, it's a normal one, okay? Here is a notching. And also we put the percentile index if more than 90 percentile, notching, and also the PI reading. So detection rate is about 40%. However, the false positive about 5%. Okay, all right. So the tools for prediction, these are maternal risk factor, blood pressure, mean arterial pressure, biomarkers, and also uterine artery Doppler. Okay, if we combine all the method, detection rate is more better, about 82%. But I already emphasized, okay, in our setup, in our pop-up website, okay, we just focus on the maternal risk factor and also the blood pressure monitoring. Okay, so the challenges, okay, she is unpredictable and progressive. Preventive strategies are limited. So only non-cure is delivery. Whatever is delivery for the treatment. So early prevention is better than cure. Okay. So again, all right, preconception counseling, early prevention. Okay. So already known the mother has hypertension before pregnancy. So preconception counseling is very important. Okay, so we have to advise mother. Okay, all right. Maybe we can see first her medication, antihypertensive drug. We revise the medication, optimize her antihypertension drug. Okay, and educate, discuss regarding the risk development of preeclampsia, risk of future pregnancy, what the complication to the mother, what complication to the baby. All right, they must understood. If they agree and understood, keen to conceive, okay, we have respect dia punya choice, and we further discussion dia ada lah. All right, so dietary intervention, okay, dietary intervention, all right. Bukan nak suruh dia kurus, tapi sebenarnya untuk maintain dia punya berat badan. Kalau dapat berat badan idea is lagi bagus lah kan, sebab dia better outcome. So exercise also, exercise can reduce risk 30%. Gestational hypertension, about 40% of PE, tinggi tu, they can reduce the risk. And also stop smoking, alright, okay. And the last one, if their patient is not ready, client is not ready to conceive, we offer the family planning. Okay, kita cakap, okay, puan tekanan darah puan masih tak optimize, tak cukup lagi, alright, puan nak mengandung, boleh, okay, kita merancang keluarga dulu, kita guna kaedah yang perancang keluarga yang betul, and then sementara tu kita make sure puan punya tekanan darah semua cantik sebelum puan pergi mengandung lah. Okay, we offer the family planning also. Alright. So there are preconception counseling. Okay, we see the future. We see the prevalence of development of the preeclampsia. Okay, here a type of hypertension in current or previous pregnancy. Okay, how about the future pregnancy? Okay, if look at this, any hypertension in current pregnancy, for the future pregnancy, 1 in 5 women, okay, about 20% in future pregnancy develop again any hypertension. Okay, preeclampsia, current pregnancy is preeclampsia, or he had previous of a preeclampsia. Okay, so she can develop another preeclampsia about 60%. Okay, all right. If the current pregnancy she had preterm delivery of because of preeclampsia, future pregnancy, okay, the risk is higher, about 33%. Okay, if she had history of preeclampsia and delivered the baby more than 34 weeks, okay, the risk about 23%. Okay, all right, and also gestational hypertension, okay, can develop and any types of hypertension in future pregnancy about 22%, 1 in 5. Tinggi ni sebenarnya. Alright, that's why kita kena optimize kan patient yang already chronic hypertension, optimize the blood pressure, optimize the antihypertensive, okay, optimize her lifestyle, okay, before she embark to conceive. Alright. Okay, prevention of preeclampsia. Okay, alright. So dia dah conception counseling dia dah faham semua, and then she conceive. Okay, what else kita boleh bantu untuk prevent? Okay, alright, especially for those already chronic hypertension, can they develop, because they can develop chronic hypertension with superimposed preeclampsia. Okay, we can offer the low dose aspirin. Okay, low dose aspirin 100 to 150 milligram. Okay, usually we give the aspirin 150 milligram. Alright, for those patient not tolerable with aspirin, we can offer the cadiprin 100 milligram. Alright, so preferable low dose aspirin we start from the 12 weeks and before the 16-week gestation and continue until delivery. Okay, alright. We can, kalau kata patient late booker, dia datang booking dah 18 weeks or 20 weeks, alright. Okay, there is insufficient data. Either the patient with late booker at more than 16 weeks or more than 20 weeks, there is any benefit for the low dose aspirin. Okay, you nak bagi boleh, alright. You tak nak bagi pun tak ada masalah. Tapi kalau patient come with early antenatal booking, alright, you dah tengok the mother has respected the blood preeclampsia. Oh, kalau the mother check BP or BP dia high, okay, you dah label as a chronic hypertension, you start the low dose aspirin. Okay, right, to one. Okay, the second one you can give the calcium 1 gram per day. Okay, so kalau kita tengok trend sekarang, all the mother kita bagi calcium carbonate 1 gram. Okay, for the cap trial, actually sebenarnya calcium ni we give the calcium for those and mother with low calcium dietary intake. So the benefit more on the mother with the low calcium dietary intake. Okay, so they can reduce the risk of preeclampsia. Okay, for mother the high risk calcium intake, alright, there is no beneficial lah. Tapi it's okay, we can just give the low dose aspirin and calcium together for all our mother with the history of a high risk group. Okay, alright. Okay, once they develop hypertension or requiring the antihypertensive, okay, saya nak patah balik. Okay, ada concurrent review short. Okay, concurrent review short, reduce risk development of preeclampsia and also neonatal complication. Tapi once already start antihypertensive, how we want to control? Okay, kejap nak naik dos ke, tiba-tiba boleh tengah jalan nak stop dos ke, alright. So kita akan tengok sama ada nak less tight control atau tight control. Alright, antihypertensive drug, a few drugs, a group either we have usually use metidopa, alright, nifedipine or labetalol. Alright, there is no the first line, second line or third line. Alright, we have choice the proper antihypertensive drug to the patient on the patient. Okay, alright. Okay, there's a few guidelines, all right? SAOG, WHO, NICE, Canada, and also International Society Study Hypertension Pregnancy. Okay, so they start mostly all of them will start the medication if the blood pressure more than 140/90. Okay, so the target as a NICE guideline, okay, less or equal to the 135/85, SHP, all right, 110 to 140, that's the 85. Okay, usually we use follow the NICE and also SHP. Kalau SAOG, okay, their target 120 to 159 and 80 to 105. Untuk if the chronic is can high, diastolic is higher up compared to is non-chronic. Okay, all right. Continuation antihypertensive therapy, right, for the NICE guideline, okay, is less than 110 to 70. Okay, can stop the antihypertensive. Okay, why you need the target? All right, it's a very low blood pressure. Okay, so we worried about the uteroplacenta perfusion lah. Okay, that's why you have a target. Not too high, not too low. Okay, tengah-tengah lah. Alright, okay. Let's start versus type control blood pressure. There is two study. Okay, there is two large study. Okay, first is CHIP trial. Okay, control of hypertension in pregnant study. Okay, so they enroll chronic hypertension. 70% is a chronic hypertension, and another 25% is gestational hypertension. Okay, for less tight control. Okay, they use diastolic blood pressure is 100 millimeter mercury. Tight control use 85 millimeter mercury. Systolic blood pressure same, less than 160. Okay, so from this study, right, the result showed development of severe preeclampsia more in less tight control. Okay, that's why in NICE guideline, all right, they use the diastolic blood pressure less than 85. Okay, the current study, all right, just released is chronic hypertension and pregnancy CHAP trial. Okay, so they use the mild chronic hypertension. Okay, mother with mild chronic hypertension. One group receive antihypertensive, another group not receive the treatment. Okay, the strategy targeting. Okay, for the study, show the blood pressure less than 140/90 with high antihypertensive have better outcome. All right. So again, when we monitor the patient, okay, in our PERPAT result, already start on the medication. Okay, look at the BP monitoring. So make sure the blood pressure achieve the target less than 140/90. Okay, but it's still high. Maybe you can add on or you optimize a single agent, and then after that you can add the second or third agent. Okay. Tapi kalau kata dah susah you control, it's better you refer the tertiary hospital lah. Okay. Okay. So mostly the others guideline 140/90 lah. Okay. So early detection and prompt treatment result in favorable prognosis both mother and fetus. Okay. So usually objective of management hypertensive disorder in pregnancy, first we make sure cure the prevent the progression. Close monitoring. We have the close monitoring. The mother, especially high risk group, monitor the blood pressure. Okay, we can do the urine dipstick proteinuria. Okay, all right, and especially after we already start the antihypertensive also. Okay, we monitor mother either can tolerate the antihypertensive, either the mother compliant with the antihypertensive, and also the blood pressure must achieve the target lah. Alright. Other than that, we can monitor the fetal. Sebab kita nak avoid mother develop the fetal develop the IUCR. So we can start the serial growth monitoring or surveillance after the 26 weeks and above. Okay, kalau kita detect nampak the growth less than 10 or 5th centile, we have to refer the tertiary hospital. ataupun it's not the growth is not less than 10 centi but static. Okay, 2 consecutive antenatal visit, the static, growth is static and then terus refer. Jangan tunggu yang ketiga, keempat ke apa. Nampak dia static, 2 kali static dia punya growth, okay, refer. How you know the growth static ke reduce ke apa semua? Kita pakai growth chart kan. So I hope all the result pepat ada simpan growth chart tu. Okay, nampak ya kita this one mother high risk. Okay, memang BP dia semua cantik, apa cantik, bagus, makan ubat. Okay, kita kita monitor buat kata mother, okay kita buat serial growth surveillance, kita chat, make sure the baby grows properly lah. Okay, alright, and also kita promote fetal maturity. Okay, as long as kita prolong the pregnancy more than 34 weeks gestation is a good prognosis. Unless okay we already suspect or identify the IGR, okay we consider corticosteroid lah. So corticosteroid can be given around 24 to 34 weeks gestation. Depends on the facility of the tertiary hospital. Okay, alright. Contoh macam kalau produk dulu, kita tak ada NSU backup. Jadi kalau kata we suspect IGR or SGA nak delivered ke apa, tapi baby already 35, maybe we can offer, okay, we consider corticosteroid even though the pregnancy already more than 34 weeks. Kalau tertiary hospital, they usually okay. The facility very good backup with NICU apa semua. Okay, sometimes after 34 weeks, then they know for the corticosteroid. Delivery. So delivery is the best today, best way and the best place lah. Kita make sure. Okay, alright. And again, we have prevent, manage the complication. Alright. Kalau kata mother tiba-tiba develop severe preeclampsia, develop eclampsia, okay. Jadi kita akan refer, of course we have to refer patient to the tertiary. Tapi kalau sekiranya dia berlaku ke our result pepat, apa nak buat? Kan? Right? So don't panic, alright. So my suggestion, okay, you create atau you buat satu box, kita panggil preeclampsia box, yang mana kalau kata dalam box tu patient preeclampsia box ada drip, ada CBD, okay, ada all antihypertensive drug yang kita guna untuk acute, ada med-sub, alright. So kita tak panik bila ada patient tiba-tiba datang dengan eclampsia, patient datang very severe PE, okay, kita ambil box tu, alright, kita manage properly, okay, explain med-sub kan, macam mana nak apa tu dilute dia, macam mana nak bagi, okay, alright. Right, so postnatal care, alright, postnatal care, alright, after delivery, of course we know that tadi delivery is the treatment, okay. So you have monitor the BP shortly after delivery. If normotensive, repeat within the 6 hours. At least we monitor the blood pressure in the 24 hours. However, for those yang ada severe preeclampsia, at least 72 hours. Mostly we monitor, keep the patient until day 5. Why? The 72 hours are very important, okay. Because that time, alright, patient can develop another severe preeclampsia, okay, alright, or can develop the severe APO. Okay, that's why you keep patient. Jangan suka-suka hati 24 hours after delivery nampak dia okay apa, discharge. No, okay, alright. So do not stop antihypertensive abruptly. Kalau for the patient on metidopa, okay, we change the other antihypertensive such as either we can use the nifedipine or labetalol, okay. But for those yang already chronic hypertension on amlodipine, okay, can change to the amlodipine. Do not stop. Okay, again, there is a window period about 72 hours. Okay, so you can develop anytime. Have developed severe preeclampsia. Okay, once patient discharge, we do home visits monitoring within the 7 days of delivery and check up again within 7 to 14 days and 6 weeks postpartum. Apa kita nak buat waktu tu? Again, kita monitor the blood pressure, achieve our target. Okay, postnatal patient, okay, our target usually blood pressure less than 150, the sleep less than 100. Okay, all right, and then we can revise the medication. Okay, that time, okay, you can tengok kalau cantik the BP is okay, cantik apa semua. All right, maybe you can slowly stop the antihypertensive. Kalau kata masih borderline, okay, tak apa, just continue the antihypertensive. Okay, all right, then we educate the other warning signs of preeclampsia, such as headache, okay, nausea, vomiting, epigastric pain, visual disturbance. Okay, any signs of preeclampsia, either one, okay, make sure mother go to the nearest, okay, the nearest hospital. Okay, and also lastly, family planning counseling. All right, I think that's all. Any questions?
Thank you, Ma'am Rustini. We have few questions here, ma'am. The first one is, in severe preeclampsia, which will be the best drug of choice, labetalol or hydrolazine? This question is from our house officer, Lieutenant Dr. T.
Okay, usually you use the labetalol. Okay, all right. There's enough. The labetalol is a first line lah compared to the hydrolazine.
Thanks, ma'am. The second question is actually from me, ma'am. Can patients still have PE without proteinuria?
Yes, can. Okay,
Can.
can. There's a new criteria. Okay, kita go back tadi our classification. Okay, the definition of the preeclampsia, either high BP plus the proteinuria, or proteinuria, no proteinuria, but they involve the end target organ. Okay, and target organ, renal, liver, okay, brain, okay, or just only high BP, but she has IGR. Okay, so already dah classified as a preeclampsia.
Okay, ma'am. So if we have a high BP without proteinuria, we still have to, preeclampsia still cannot be ruled out, right, ma'am? Still, we have to be more vigilant to think for the preeclampsia, right, ma'am?
Yes, that's right.
Ma'am, the next question, ma'am. The association between uric acid level and preeclampsia is also from our house officer, Dr. Puvi, Lieutenant Dr. Puvi. She wants to, the question is from her, ma'am.
Sorry, Sanggari, association with what?
Uric acid level and the severity of preeclampsia, ma'am.
Oh, uric acid. No, there is no association.
No direct association.
So you cannot predict the high uric acid, she developed the severe preeclampsia. No.
I think for now, I only received these questions, ma'am. Then if anyone have more questions, and you all can, I think, can message Dr. Rustini by yourself to get more get more clearer pictures lah, ma'am. Is it okay, ma'am? I ask them to message ma'am straight, ah?
Boleh je, anytime.
Okay. Thank you, ma'am.
Right.
Okay.
We will call Colonel Dr. Che Hasnura again to deliver her next topic. Is actually regarding abnormal uterine bleeding. I hope all of y'all still staying tuned and listening and following our webinar. Okay, ma'am?
Okay. Thank you so much, Sangari.
Thank you, ma'am.
So next, moving on to the next topic lah. So abnormal uterine bleeding is one of the topic that is actually quite lengthy. However, I will try to emphasize on what is the important aspect, or what is the important assessment and diagnosis, and how to manage it at your center, and then also when to refer and all that. So this is the outline of the talk today. So before we discuss on abnormal uterine bleeding, you have to bear in mind of your normal menstrual cycle first, okay? So normal interval of menstruation is usually, we take it about 24 to 34 days. But normal in certain people might be from menarche, they only have like 2 to 3 months menses without having other problems also. So you have to take the history properly so that you know either this is currently an abnormal bleeding or not. Regularity, we take a range of 2 to 20 days. Some people will just have about 2 days, 20 days, and then after that, 24 days later, they're going to have their menses for 2 days again. Okay, that will be normal for that person. And duration, it can extend from 4 to 8 days. It doesn't mean that if I have 4 days, 5 days, you have 2 days that yours is normal, yours is abnormal. No, if they are usually like that, they are most probably normal, unless they have some other issues pertaining to that. That means they have other symptoms that is associated with that, okay? And the volume, no, none of us are actually measuring the volume as you know, kita tak quantify the volume, the actual volume, but we take normal as about in between 5 to 80 mils. So when is the bleeding abnormal? Kan? So when we're talking about abnormal uterine bleeding, it is either they have problem with the regularity, the length, the cycles compared to their normal previous cycle. So when they have a bleeding or spotting in between periods, the intermenstrual bleeding, bleeding after sex, that's postcoital bleeding, heavy menstruation compared to her previous one, menstrual cycles that are longer or shorter than the previous cycle, irregular period, and also bleeding after menopause. The one that is worrying us the most, actually, if we have any of this patient that comes to us, is either is of course the bleeding after menopause, because once menopause has set in, you should not have any pervaginal bleeding. Okay. So there are a lot of terms that has been used regularly in the past, in which it have been confusing a lot of medical students, especially with all these terms they have to remember. However, we have make it easy. I mean, the society has make it easy for everybody just to use abnormal uterine bleeding, and then just specify what type of abnormality that they have. So heavy menstrual bleeding, like I said before, it doesn't mean that, you know, some people heavy will be the same as your heaviness, you know. As long as the menstruation at that time is described or perceived by the patient that it is excessive and it interferes with her physical, emotional, social, and quality of life, then you should be taking the complaint seriously, and in which this could occur alone or even in combination with other symptoms. So FIGO have further classified it with the use of palm Cohen classification, Abnormal uterine bleeding is anything that is abnormal from their normal menstrual cycle. Acute one, I mean, they have an episode of heavy bleeding that is sufficient enough to cause some problems, but chronic if it's lasted more than 6 months. Then acute AUB can be spontaneous or in context of chronic AUB. Chronic AUB can be more than 6 months. However, sometimes it is acute and sometimes it is actually normal. Okay. Then the heavy menstrual bleeding, like I said, as long as it affects the quality of life, you should be taking it seriously. Subjectively, people have abnormal limits of the blood loss. But if you want to objectively quantify, it is usually those with blood loss more than 80 ml per cycle, and 60% of these women will also have evidence of iron deficiency anemia. So palm coin classification is used since 2011 for us to classify in which group of these people that come with abnormal uterine bleeding. So what does this abbreviation is used for? Is P for polyp, A for adenomyosis, L for leiomyoma fibroid, M for malignancy or hyperplasia, and then S for submucosal. Dia further specify the leiomyoma ada lagi dia punya group submucosal or other groups lagi, and then current means coagulopathy, ovulatory dysfunction, endometrial iatrogenic. So, and the last one will be not yet classified or previously known as dysfunctional uterine bleeding. So the further sub-classification of leiomyoma, we have submucosal, we have others and others, depending, we are giving them numbers to either intramural, subserosal more than 50%, subserosal less than 50%. But this is actually more important for gynecologists who are doing the operation, as far as to decide which type of operation that is needed for them. But as long as you guys know the palm coin classification and refer to us with that palm coin classification, that will be very, very much helpful. So the polyp is actually rarely to be malignant. However, there's also a small number that can be malignant or malignant features. It is actually just additional epithelial epithelial tissue. So the increase in proliferation of the vessels, glandular or the muscular connective tissue that leads it to be more prominent than other normal tissue surrounding it. It can be presented with symptoms. It can also be just finding, like accidental findings during your infertility treatment, infertility screening. So it is important to know either there's the ultrasound features are usually be more prominent if you're using a saline infusion and put the fluid inside the cavity, and then you can see a dangling tissue clearly that signifies that it's a polyp. Then we have adenomyosis. Adenomyosis is actually a subgroup of endometriosis. Endometriosis is such a huge thing, in which if it's the tissue associated with endometriosis seeps into the myometrium, it will then leads to this adenomyosis. There are many risk factors that is associated or promoting the patient to have adenomyosis, like if those patients with multiparity, because every time you deliver a baby, there's some damage to your endometrial, there's some breach of your endometrial cavity that allows this endometrial tissue, endometriotic tissue, to seep into your endometrial myometrium, then leads to production of adenomyosis. Same goes to during DNC of miscarriage. So there are some breach of the endometrial cavity that leads to insinuation of this tissue into the myometrium. People are oftenly confused in between adenomyosis with fibroids. Fibroids, depending, rarely, most of the time, the dysmenorrhea will not be as bad as adenomyosis. If the chronic pelvic pain is so severe, you might be thinking the level of adenomyosis than fibroid. Another ways to differentiate it would be from ultrasound. If in an ultrasound, the fibroid will be encapsulated nicely, while adenomyosis, you see something is bulky, but you can't determine the outline of the growth. Leiomyoma is, I think I will talk in detail about leiomyoma a little bit later on. So it is actually a tumor, a benign fibromuscular tumor, but it also has about 1 to 2% chances of changing to sarcoma. So whenever you have a fibroid, you have to monitor even how small it is, or how, of course, big, you will refer to gynecologist straight away. But if it's small, you can just monitor so that it will not have a sudden onset of growth that will then suggest that it could be a cancer. When talking about fibroid, about as many as 1 in 3 women will develop this leiomyoma. The risk factors are those with high level of estrogen and progesterone. Previously, we thought it's just the estrogen that is actually the culprit for fibroid, but it's actually both the estrogen and progesterone. And those nulliparous individuals are also at high risk. Okay, they usually come with heavy menses, abdominal pain, lower back pain, constipation, urinary frequency, and pain during sex, depending on the location of the fibroids. Okay, at birth, they will come with complication during pregnancy itself with malpresentation, and after birth with PPH and all that. And occasionally, they will come with issue of fertility. So whenever you have a patient comes to you with menstrual changes, abdominal, urinary problems, and pain, pressure, reproductive problems, you must be thinking in the line of fibroid, so that you will not miss to screen for actual fibroid to be there. Then M is for malignancy and hyperplasia. For those patients with underlying obesity, PCOS, nulliparous, they are having this unopposed hyperestrogenic state. So in which this will then predispose the endometrial cavity to change into endometrial tissue to change to hyperplasia, which is actually a pre-malignant state of endometrial carcinoma. C for coagulopathy. Coagulopathy, the most common one that leads to heavy menses, von Willebrand disease, rarely being screened. However, if the patient been having heavy menses since menarche, you must be thinking in the line of von Willebrand disease. And if any of these following are present, I mean, if they had a postpartum hemorrhage, they always have surgical bleed, or even a minor surgery, they have a surgical bleed, dental bleed, and 2 of these following, like bruising, epistaxis, gall bleeding, family history of bleeding, there you need to screen them for von Willebrand disease. Ovulatory dysfunction are those that we have mentioned earlier, those polycystic ovarian, those with hypothyroidism, they will have some changes in their menstrual cycle, in which they usually come with heavy menses. Hyperthyroidism usually will come with irregular menses rather than heavy menses. Okay, hyperproteinemia, either they will come with that, or amenorrhea. Mental stress, obesity, anorexia, all can lead to some problem with their menstruation, but more so of irregular menses than heavy menses. Okay, it could also be iatrogenic, because those patients was on steroids, on the those medication that affect your dopamine metabolism, will then have some degree of abnormal uterine bleeding, because they change it at the central level. And there are some unexplained condition in which if you notice some patient comes to you after menarche, the first 2 years of menarche, they're gonna have some irregularity, heavy menses, they're gonna have problems before they get the regular cycle that they should have. We're gonna give them about 2 years, provided that they are not having some complication from it. Like if they're heavy menses but they're anemic, of course you have to refer them early. But they have heavy menses, but HB has been 14 to 16 all the while. So that means the perception is high, but it doesn't reflect in the actual physiology of the body. Okay, and of course during the menopause transition. Then endometrial, we also have some other, besides malignancy, we have infection, inflammation, endometritis that leads to abnormal uterine bleeding. Iatrogenic, sometimes those who are on medication, they have some breakthrough bleeding. And those who are on COCPs also sometimes have prolonged bleeding, breakthrough bleeding. So you need to get the drug history well, just to make sure that they are not on medication that can alter their menstrual cycle. And then of course the last one is not yet classified. Like I said previously, it is known as dysfunctional uterine bleeding. It is a diagnosis of exclusion. You exclude semua sekali tadi yang kat atas tu, baru you can classify the patient as DUB. Okay, other relevant history. Rule out pregnancy, because we have seen patients that thought that they're having menses, but they are actually pregnant. I mean, they are either ada one patient tu, they are actually passed out POC 2 months prior, but they keep on having bleeding. They thought it was all finished, but actually there's some still inside that need to be operated on. I mean, we have to do suction for that patient. And the other patient is sometimes they have implantation bleeding like earlier on. That's also causing some intermenstrual bleed for the patient. And then previous pregnancy miscarriage history, like PPH I told you earlier, is very important, because those who are having problem coagulopathy like bone remnant disease, sometimes they just come with PPH every pregnancy saja. During pregnancy antenatal, no problem, anemia tak ada. Dan waktu bersalin saja mesti PPH, but you don't know why. But then you have to screen them for this problem. Then medical history, family history, usually like adenomyosis, uterine fibroid, there are some family genetic inclination towards it. So usually they have gonna have either siblings or parents or mother that will have the similar issue. And the social history stress. This is almost like everybody is having stress, but no, not everybody is having menstrual problem. But you have to know which level of their coping mechanism and their exposure to stress, to how they deal with it and all that. Because some people might need to even refer to psychiatry just to get it settled with. Yeah. So physical examination. Generally, the severity is assessed with any sign of hyperandrogenism for polycystic ovarian. Neck swelling, because sometimes they come with Hashimoto thyroiditis, and also they're going to have some goiter. Breast, any breast mass is important in 2 ways. Sometimes it's not the breast mass that causes the bleeding. You know, sometimes the breast mass is actually a cancerous, which is also having other pelvic masses that might lead to this kind of problem. Also, it is good to know either they are, before you start any treatment, that they're having any breast cancer or not. Okay. Then abdomen, to see any pelvic masses, ascites. Bimanual examination is just to strengthen your abdominal examination findings. Okay, whenever you have chronic AUB, then you have to start investigating a little bit more in depth. Before you, while you're doing your bimanual examination, just proceed with pap smear and KIV specular examination with pap smear and KIV endometrial sampling. Because sometimes, you know what, you can see endometrial polyp down there. So whenever there's a polyp inflamed, of course it's going to bleed. Sometimes it's just the cervicitis that you can also treat there without even referring to the hospital. You just assess, tengok ada infection, you just start on medication first. If it's BV, just start on flagyl for 1 week, and then to see again either the problem persisted or not. Okay, and then PIPEL if indicated. Of course, in result purpose there's no PIPEL. The PIPEL tu you tak ada, so it is better to just refer to us. Okay. The endometrial assessment is mainly to see if there's any polyp. And of course, polyp and malignancy, endometrial carcinoma, hyperplasia will be in different presentation lah. So risk of malignancy is very much important to be excluded in those who are obese more than 90 kilo, infertile patient, nulliparous, age more than 45, family history of colorectal, breast, endometrial CA, and of course those who are having diabetes, hypertension, that may increase risk to get endometrial carcinoma. In between PPL sampling and also hysteroscopic DDNC, of course, if you can get the patient to agree on hysteroscopic DDNC in those high-risk patients, you're going to get a lot more values from your hysteroscopic DDNC than your PPL sampling. Investigation, baseline, full blood count, of course, patient can say many things, many problems, many complaints. HB12. So either you want to see her now, or you want to see her 1 month later. You can see her 1 month later, okay? But if it's always in the datang walaupun satu episode tapi HB dah 9, 8 semua, that means it is severe enough to cause some changes into her physiological aspect lah. So but you have to know the patient's HB prior to that so that you can compare, okay? Don't forget to do your UPT, coagulation profile. If you suspect any problem with coagulopathy, or if you see that platelet is low, then you proceed with coagulation profile. Hormonal profile, especially the TSH is important. And sometimes FSH, LH, if you see that the patient could be a perimenopausal, so you want to see whether this is actually a perimenopausal condition or not, okay? Tumor markers, if only indicated any pelvic mass, baru buat tumor markers. Any pelvic mass, scan ada cyst, baru buat tumor markers. Do not do for everybody. And specific markers, example is vulnerable factor lah. So imaging, every result purport has an ultrasound, betul? Everybody should know. Should know is macam keras sangat. Everybody needs to be familiarized with your machine. Okay, tak semua machine will come up with a good picture, but you need to orientate yourself every time you go to any result purport, any center. The first thing you do is to check your ultrasound machine. So to know how to use it, because it's very, very useful and it should assist you in many, many ways. Okay, so the first thing you do with a gynae scan, find the bladder first. Selagi tak nampak bladder, that means susah nak jumpa uterus. Bladder and uterus tu ialah side by side, adik-beradik, sebelah saja. Atas bawah lah. Depending on the bladder is full or not. Satu, find bladder. Number 2 is make sure the bladder is full. If you cannot see the bladder, takkanlah dia tak ada bladder, betul tak? So what you're gonna do is you're gonna ask her to drink about 1 liter, and then datang balik. You don't ask, cakap kat patient, pergi minum sekejap, satu teguk, then dia kena come back. Then you can scan, dan tak ada lagi. Tak boleh lah. So you have to ask them to drink at least 1 liter, wait until they feel the sensation that they want to pass urine. Then baru masuk bilik, then you can scan them properly. The first thing, uterus. After the bladder, the uterus. Uterus the position kat mana? Axial, anteverted, retroverted. I hope everybody knows how to look at the position of the uterus. Number 2, tengok besar sangat ke kecil? Kecil sangat, selalunya atrophic budak-budak ataupun tak puberty lagi, ataupun those menopause lah, should be atrophic. So what is the normal size? Kena tahu normal size berapa. Okay? Kalau by inch is 1 times 2 times 3 inch. Kalau by centimeter, 5 times 6 times 7. Okay? Nothing more than that, usually kita panggil bulky uterus. So bulky uterus ni sebab apa? Nak tahu sebab apa, you have to check the endometrial cavity dulu. Cari endometrial lining, jumpa tak? Kalau endometrial lining tu jumpa cantik, tak ada ke atas ke bawah, tak ada benda tolak dia ke atas ke bawah ke tepi ke apa ke, that means the whole uterus is globally enlarged, then it means it could be an adenomyosis. Tetapi kalau dia ada setempat saja yang nampak macam ada growth, dan nampak macam clear dia punya outline tu, it must be fibroid lah. That's how you see. Then baru you turn your probe to transverse, tengok kiri kanan, tengok ovary, and also the anissa lah. Anissa means ovary and fallopian tube. Okay, and also free fluid. Free fluid findings for those reproductive age group, menses or near menses is quite normal. Okay, but you have to then tengok symptoms patient. Sometimes it's PID pun ada free fluid juga, tapi dia ada symptom sakit, datang demam and all that. So that's how you play along with your gynae scan. Okay. Transvaginal scan, kalau everybody knows how to do it, will be fantastic. At least try to do it, because The endometrial lining, a lot of information, it's more clear with transvaginal scan. So you see from this picture, what is your diagnosis? It's a polyp. It's obviously there's a polyp there, okay? So from transvaginal scan also you have to know retroverted ke, antiverted ke, and then nak pergi macam mana, you have to learn how to use your probe properly. Then this is what I mean about cell line infusion sonography. You put in a catheter, Foley's catheter into the cavity, use the smallest one usually, the pit size, and then insert it into the endometrial cavity, and then you infuse and then you do a scan. So you can see the polyp more clearly. And then next will be imaging. If like CT scan or MRI, if satu, you'd want to see the operability of the mass. Number two, if you are suspecting any cancers, so that you don't miss out and you will do a good operation rather than just blindly do it with just your ultrasound scan. Okay. So this is how you assess. The picture is a bit small, but on the picture you can see if it's a polyp, then the feature dia macam tu. Adenomyosis, usually to differentiate within fibroid dengan adenomyosis. The common referral, which is actually selalu salah to us, is to rule out fibroid, in which actually the uterus is retroverted uterus sahaja. Because why? Because when you see the cervix, cervix, you are expecting the cervix and the body of the uterus go like straight and up. So whenever it goes down, then which is retroverted, acutely retroverted, then you guys started to think that it's a fibroid, which is not. So sebab tu I cakap buat with full bladder and then decide dulu dia retroverted ke, antiverted ke, apa ke. Then baru you tahu ada fibroid ke, tak ada fibroid ke, apa ke. Okay. And then kalau from scan juga, you can see polycystic ovarian clearly. Endometrial CA, if it's a CA level, you can even see at the endometrial lining too that the features are not like hyperplasia, just the thickened endometrium. You can see that there's some fungating mass into the myometrium also. So treatment, of course, the main thing is to stop bleeding. Whenever they come to you, make sure how to stop bleeding first. You have all your tranexamic, mefenamic acid in your resap pepat, use that, okay? Iron supplementation, if she's bleeding heavily, HB baru turun 10, kan? Usually dia 13. Okay, just bagi iron supplementation. Increase to ibuprofen or zinc copper, bagi tu. Jangan bagi albumin saja. Okay, so increasekan dia punya tu for therapeutic level. And medical, we have non-hormonal, hormonal management, surgical management, and combined therapy. So which one that we usually hospitalize? Of course, those with signs of impending shock lah, hemodynamically unstable, with tachycardia, hypertension, HB low, mainly if it's requiring blood transfusion, we're going to admit, but sometimes if it's less than 10, we're going to give IV, Venofer or Cosmofer. Then if they are symptomatic, HB11, we still admit because sometimes your lab also ada lab error juga kan. So sometimes you just do that, especially if you see that the patient is like punctured, you still admit. And then if HB12, you repeat. Okay, so it's just you go by your clinical judgment rather than your investigation. Okay, and then if you need an IV estrogen, which we don't give usually, and need any surgical intervention. Some patients need urgent surgical intervention because why? If you don't do it, they're going to continue to bleed. Contoh, molar pregnancy. Molar pregnancy, if there's bleed, lepas tu biar saja dia akan continue bleed because the culprit is still there. Okay, but for those yang macam AUB secondary to NOS, DUB lah. So if you start on hormonal therapy, dia akan respond well. So how to stop the bleeding? Of course, mefenamic acid versus tranexamic acid. With mefenamic acid saja, there will be about 20 to 40% reduction of bleeding already. So first line, recite mefenamic acid. Berapa nak bagi depending on the susceptibility of the patient. 500 is the paling sikit lah, you can go up to 1 gram juga, okay? Tranexamic acid, the same. Tranexamic acid should not be given a long time. Tranexamic acid compared to mefenamic acid, if it's associated with pain, give mefenamic acid rather than tranexamic acid, or you give both, okay? Tapi kalau ada satu, mefenamic acid, kalau nak pilih satu sebab ada dua patient, ada dua ubat tu dua saja. Okay, nak bagi siapa yang mana? So kalau the patient with pain and bleeding, bagi mefenamic acid. So the other one with bleeding saja tapi pain tak teruk, tak apa, dia beri tranexamic acid. Okay. Tranexamic acid ni level of evidence reduction of blood loss is quite significant, but depending on the cause juga. If it's a fibroid that is huge, tranexamic acid will not work. So if it's less than 3 centimeter, tranexamic acid should be okay. Then we start with our hormonal medical management, either cyclical OCP or progesterone only therapy. Combination will be the best choice because of the control of the cycle sorry, and also the reduction of blood loss about 50 to 60%. Kejap minum air sekejap. Okay. Previously we have Clara, which is will then induce reduction of bleeding within 70 to 80%. Then we have Marina. Marina has been proven to be beneficial and to avoid hysterectomy in certain patients. Sekejap, 1 minute. Okay, sorry. Marina is good, but when you put patient on Marina, you have to advise them accordingly, because sometimes they're going to have discharge that is quite annoying, that they're going to think that they have to stop or to remove the IUCD. Oh, sorry, the Marina. The effect of Marina on the endometrial, dia ni bagus in terms of patient with DUB, patient with small fibroid, with adenomyosis, because it has a reduction of bleeding up to 80% within the first 6 months. And of course, at the same time, reduce of pain, chronic pelvic pain, in about 40 to 50%. The effect is not immediate, so you have to ask them to be patient, because about 3 to 6 months, then baru ada the maximal effect of the Marina. The bleeding pattern, sometimes you're going to have some spotting, which improve after 6 months. So you just have to educate your patient when they are on Marina. Effectively, memang reduce blood loss. It has become the game changer to avoid hysterectomy in a certain patient. The quality of life also is better. And then, and because of that, the continuation rate for 5 years is almost like 98%. Next will be endometrial ablation. Either we do a transcervical resection, a roller ball, laser, thermal, a cryo ablation, or even a microwave endometrial ablation. Endometrial ablation is useful if the patient has no future childbearing plans, and there's the chance of endometrial cancer has been ruled out. So this is how we do a transcervical resection of endometrium. Then I'm just going to touch on management and intervention with fibroid, which is one of the commonest referral from the receptor partner. So fibroid, now, like I said, 1 in 3 women has it, either they're symptomatic or asymptomatic. Kalau dia asymptomatic, you can just monitor in your center, tak ada masalah. Especially if it's smaller than 3 centimeter. But if it's symptomatic, regardless of the size, you have to refer. Okay. Premenopausal, the management will be depending whether they still wanted to be pregnant, they want to save their uterus, or they are actually okay with removing everything. And then for postmenopausal, with fibroid, you still have to do some endometrial biopsy and also imaging to then proceed to hysterectomy monument. Okay. Expected management of fibroid, if those are asymptomatic, and then you need regular follow-up at least 6 monthly. Fibroids often shrink after menopause, and symptoms usually ease after that, but it might still be persistent because it might be something else. Especially if it's persistent postmenopausally, you must be thinking the line of uterine sarcoma. Okay, criteria fitting for expected management, like I said, asymptomatic, size of less than 12 weeks, and then age factor nearing menopause and has completed family. Intervention, we can either intervene medically, radiologically, or surgically, but medical intervention is only temporary. So we have either emerging therapies. Surgically, we have also magnetic resonance imaging focused ultrasound, and also we have myolysis. And medical, we have SMIA. Okay, for GRH analog, in which it will the use of Lucrine or GRH analog are not supposed to be a medical therapy. I mean, it's not supposed to be a treatment per se on its own, because it is usually given just pre-operatively to improve the hemoglobin level, to reduce the vascularity during operation, and then we still need to proceed with operation. There are no patients that have been on Lucrine injection that then later on will avoid operation altogether. Okay, this is only a temporary measures to improve the condition that I've said earlier. Then we have another medical therapy. We call it SPRM actually. It is an alloprostate acetate in which it affects directly on the fibroid, endometrium, and also to the pituitary. What it does is actually it reduces in the bleeding related to fibroid, reduce the volume, improve the quality of life, and has been used also for adjunct pre-op therapy. It is a good alternative for those who are so scared of operation and also wanted to preserve their operation, preserve their uterus altogether. However, it was being pulled out from the market about 1 year back due to the serious liver effect that some has to even go for a liver transplant in certain European countries. But however, this is a potential drug that might be emerging back later as a mode of treatment because of the acceptability of the patient and also the effect towards the fibroid itself. But however, now it is still being banned to be used for fibroids. Then we also have a radiological option in which you don't have to go for operation, UAE, and the focused ultrasound using magnetic resonance machine. In UAE, it involves blocking the blood and cause the blood supply and cause the fibroid to shrink. While the magnetic resonance guided focused ultrasound is also targeted laser beam or therapy, laser energy and ultrasound energy directly to the fibroid cell. So this is how UAE works, in which we put in a catheter in the from the femoral cavity to reach, so that it will then supply to the uterus and fibroid. It will then block by using a medication to block the flow towards the organ and also shrink the fibroid. But knowing about UAE, if it's pregnancy is wanted, it might be a bit difficult because to offer UAE, because sometimes the blockage doesn't know which one that it blocks. You know, sometimes it blocks the ovary and leads to menopause. So that's why sometimes if they are not if it's a fertility sparing, that is not going to be beneficial to suggest them to be on UAE, to go for UAE lah. The side effect is the other thing that people doesn't like to go for UAE, because immediately they have some spasm. It is done in radiological unit with anesthetist to be around, because sometimes they're gonna have like severe pain during that time that we need to give them some sedation, some medication, long stay in the hospital just for the pain. Early symptom, early complication within 30 days, they're gonna have pain, fever, malaise, UTI, DVT. Late, they're gonna have some discharges, which is like black in color because of the ischemia that been caused by the UAE itself. Efficacy, about 90% become asymptomatic after a year, and it reduces volume about 70% and avoid hysterectomy in 97% of the patient. So fertility outcome still not good. It is not advisable actually. If they still wanted it and wanted to do UAE and wanted a fertility, they might end up with the risk of uterine ischemia, rupture, and also with preterm delivery. This one is the magnetic resonance dengan ultrasound guided high intensity focus ultrasound for fibroid. We only have one in Malaysia here in Mahkota Medical Center. Procedure using MRI or focus ultrasound, thermal ablation, and then efficacy, bleeding improvement about 60 to 70%. 30% requires re-intervention. Fertility preservation is debatable. So if fertility sparing is needed, it should not be recommended. Does it work? Yes. Is it safe? It's also safe, but we have history of rehospitalization with fever and skin burn. Then the other one is surgical option, either conservative and definitive. How to select? By age factor, fertility concern, symptomatic ke tak. Preparation before, medical treatment to shrink the fibroid, and then you correct anemia. You use vasopressin during operation, intra-op, JSM on standby of anticipation of bleeding. Myomectomy can be done both open or laparoscopic, or even hysteroscopic. Hysteroscopic myomectomy will be suitable if it's a submucosal fibroid. And then we are using the last mile score to decide if it's less than 4, that it's suitable for hysteroscopic myomectomy. You need a good camera system. Side effects that need to be to look out is about fluid overload and uterine perforation and addition. Hysteroscopic myomectomy, this is how it looks like. The myoma, then the grade 1 is the best lah. So you just remove it. But grade 2 ni kadang-kadang ada risk for uterine perforation. The size should be more of intracavitary rather than at the submucosal itself. Secondary treatment will be needed. The complication, as I said earlier, uterine perforation, sepsis, fluid overload, additional treatment may be needed. Then we move to laparoscopic myomectomy, best if a single fibroid less than 10 centimeter size. Preparation, avoid using GRH analog prior because of the difficulty to delineate the capsule properly. HP must be more than 10. Precaution intra-op must use vasopressin to reduce bleeding. And the specimen removal will most later. Sometimes we do an incision at the partial Douglas to remove the fibroid. Side effects are bleeding, improper closure of defect, risk of scar lesion later. This is how we do laparoscopic myomectomy. So laparoscopic versus open myomec. Of course, open myomec going to be faster, but laparoscopic myomectomy, the acceptability lepas operation will be better because they're almost like minimal, very minimal scar and very early for them to go back to their daily activity. But of course, in any myomectomy, the risk of recurrence is still there. The pregnancy outcome after laparoscopic myomectomy, they are good, not much different from the open myomectomy. And then we have another one is myolysis. We're using a thermal probe in which we insert it either hysteroscopically or laparoscopically, and we put in the fibroid, then we give heat, and then dia akan desiccate. Okay. So this one tak ada lagi dekat kita, tapi we are being introduced with the hysteroscopic myolysis recently. We haven't done on our own yet, but hopefully we're gonna do it later. So apa effect dia? Dia boleh leads to fibroid shrinkage, symptoms free in 1 year, and then quality of life is much improved. So far, after myelinosis, 20% pregnancies reported, but they are reported PPH following expulsion of fibroid after childbirth secondary to uterine ectomy. Open myomectomy is easier. That's the picture of it. And of course, the last one will be hysterectomy, will be definitive, in which once you remove the whole uterus, there's no risk of recurrent. There will not be any other further issue regarding fibroid, because there's no other, there's no muscles or there's no tissue there anymore, right? So it is preferred if the fibroid is more than 24 weeks with invasive fibroid. This also can be done either laparoscopically or by open hysterectomy. So, of course, abdominal hysterectomy, open hysterectomy, the degree of difficulty will be lesser and higher in laparoscopic TLH in fibroid, because fibroid sometimes kalau nak buang uterus from laparoscopic, you have to do myomec first, then baru you boleh remove. These are the type of hysterectomy or the type of operation that can be done to the fibroid. So in terms of which treatment the best, you have to tailor it according to the patient needs and the patient condition. Of course, eventually hysterectomy might not be avoidable, but a lot of counseling need to be done, especially if it's adenomyosis. You should not be leaving the ovaries behind, because why? They're still going to have pain because they're the ovary. They are the risk genetically inclined to endometriosis. Remove the uterus, you leave the ovary behind, still ada cyclical pain. So dia still tak puas hati macam operation tidak berjaya. Sedangkan because we have not done a good surgery, we have not choose the right surgery for that patient. Okay. I think that's all for me. I hope in between my batuk, you can understand what I'm talking about. So sorry for that. If any questions, then I'll just take it now. Thank you.
Thank you, ma'am. I think we are running late, so I won't take any question. If anyone have a question, please PM and take personally. Is it okay, ma'am?
Okay.
Okay, ma'am. So we will go for a short break. We will be right back after 10 minutes. I hope all of y'all can come back and join our webinar. Continue our webinar at 11:20. Thank you everyone for joining us back. I hope you could catch up a small break. Now I would like to welcome Lieutenant Colonel Dr. Nur Azima binti Zakaria for our next topic, managing endometriosis.
Hi everyone. Okay, thank you for inviting me for having this webinar for presenting managing endometriosis. Okay, condition which classically defined as the presence of endometrial gland and stroma in the ectopic site of, meaning outside, and it affects about 6 to 10% of reproductive age, and prevalent rate high as 35 to 50% in women experiencing chronic pelvic pain and infertility. Okay, this is a few theories of endometriosis. The limitation theory, meaning if the woman having menorrhagia or overflow of the menses, so it can cause overflow of the menses outside of the uterus through the endometrium tissue implanted outside of the uterus, maybe outside at the ovary, okay, or at the bowel, and also at the peritoneal cavity. So the second one is cell-mate metaplasia, and also lymphatic vascular endometriosis, which cause of inflammations and adhesions formation for women having endometriosis. And also it by study, it can have a genetic prevalence, meaning if from the family member having first degree relative of family member having endometriosis, so that woman having 7-fold higher risk to have the similar problem of endometriosis. Okay, we can divide a type of endometriosis, whether pelvic endometriosis or extrapelvic endometriosis. If the pelvic endometriosis, it means it having the endometriosis is inside peritoneal cavity, okay, over the peritoneal. It can cause ovarian endometriosis, and also it can cause deep infiltrating endometriosis, mean the endometriotic tissue implanted at the bowel, bladder, and also recto-vaginal septum. For the extrapelvic endometriosis, so the endometriosis, other patient can have, other women can have other side of endometriosis, maybe at the genitourinary tract, at the bladder, okay, at the ureter. It can cause something like hematuria or cyclical hematuria during the menses, and in gastrointestinal tract at the bowel. So sometimes women will present with dyschezia. Dyschezia means cyclical rectal bleeding during the menses. And if patient having a previous scar, so the endometriosis tissue also can implanted over the scalp. And the last is thoracic or pulmonary. Very rare cases we get pulmonary endometriosis, but sometimes if patients having a symptom of chronic pelvic pain, infertility, and with symptom of hemoptysis, cyclical hemoptysis during the menses, we should suspect pulmonary endometriosis. Okay, usually endometriosis can cause pain, okay, chronic pelvic pain. Sometimes if patient presented to the GP, okay, general practice with multiple complaint of pain, but very unspecific pain like chronic pelvic pain, abdominal pain. So sometimes it took about 7 years to get conclusion or to get the confirmative diagnosis of that patient having endometriosis, because sometimes it presents with a very unspecific pain. So the pain associated in endometriosis is due to peritoneal inflammation. When inflammation happens, so a lot of cytokine productions and also growth factor lead to chronic inflammation. And when chronic inflammation happen, so it can cause scarring and also adhesion inside the pelvis, and the inflammation itself can cause irritation. And the pain also can be due to direct invasion of pelvic floor nerve by infiltrating of endometriotic implants. Okay, the sign and symptom of endometriosis. So the most common one is dysmenorrhea, meaning the woman are having pain during the menses, and patient having chronic pelvic pain. Deep dyspareunia mean pain during having sexual activity, and dyschezia mean cyclical per-rectal bleeding during the menses. And now also we can see a lot of patients with underlying endometriosis presented with infertility, especially primary infertility. So according to Bellet et al., found that 83% of women with endometriosis reported one or more of the symptoms to their GP when compared to with just 29. Means the commonest, this is the commonest sign and symptom that patient presented. Okay, and dyschezia, which is per-rectal bleeding during menses, and also deep dyspareunia or a stronger predictor of deep infiltrating endometriosis. So why women with endometriosis having a problem with infertility? Okay, in infertility related with endometriosis, usually that patient already having advanced stage or the advanced or moderate to severe stage of endometriosis. Okay, when having say that patient having a moderate to severe endometriosis, pelvic organs already a lot of adhesions and chronic inflammation happen in the pelvic organ, lead to frozen pelvis to the patient, and it can cause also impacts tubo-ovarian mobility. And for ovarian problem, usually in infertility cases, usually they already have ovarian endometriosis, which is endometrioma, which lead to anovulations, mean anovulatory and also unruptured follicle and oocyte maturation defect. So means it lead to subfertility. And other than that, when having chronic inflammation, it also cause a tubal, it affect the tubal patency, means the tubal will blockage of tube, lead to this endometriosis. And peritoneal also, there a lot of inflammation. Sometimes it will affect the sperm, which will lead to infertility. And for the patient with endometriosis also, endometrium changes environment inside the endometrium cavity or the endometrium tissue, which lead to implantation defect for the ovum or for the zygote, or for means the implantation failure. It lead to implantation failure. So when patient presented with a complaint of chronic pelvic pain, dysmenorrhea, and infertility, we need to proceed examination and a few investigation for this patient. If that patient already having married and sexually active, we can proceed with vagina examination and clinical examination. Okay, usually from general examination, we do pelvic abdominal examination if to detect if patient having any palpable mass palpable mass during abdomen examination, means we need to suspect that patient might have ovarian cyst, okay, or ovarian endometrioma. And then we proceed with vaginal examination. We need to look out any sign of endometriosis, okay. From the speculum, okay, we can see that this is the cervix, and we can see the multiple endometriotic lesions overlie the cervix, and also we can see, or we can palpate palpable. You can see also this black spot, this dark blue nodules. This is sign of endometriosis, and we can palpate for any tenderness, and you can see the nodularity. And you if that woman presented during the menses, you can see the nodule, the blackish nodule or the endometriotic nodule will increase in size, especially during menstruations. Okay, for the young woman and single, means this the single woman and young woman which not having any sexual intercourse yet, so we can appreciate these palpable nodes by doing a per-rectal examination if that patient already having like moderate to severe endometriosis. However, in the clinic, in our setup, I think we have other modalities such as ultrasound. We can do trans-abdomen or trans-vaginal. So we can appreciate better by trans-vaginal scan. Okay, to diagnose endometriosis, usually based on history taking and also by the further investigation, like by bedside ultrasound, or we can proceed with other MRI or other modalities. Okay. However, to confirm the diagnosis of endometriosis, we need to get laparoscopic. We need to proceed with laparoscopic for visualizations for the sign of endometriosis, and also to get the histopathology from the endometriotic lesion or endometriotic tissue. Okay. From laparoscopy, the aim of laparoscopy is actually we can get a full visualizations of the reproductive organ, and also we can detect other concomitant disease such as pelvic inflammatory disease, PID, or any other cyst. Like maybe that patient presented from the investigation, we can see that patient having ovarian cyst, but maybe there's not endometrioma, but this can be another cyst, another pathological cyst. So to get the biopsy or histopathology from the tissue is important confirmations of the endometriosis. And also we can see the staging of the disease, like the severity of disease according to the score. Okay, after this I will show you. Okay, like I said, the transvaginal scan, we can detect the endometriosis more clearer compared to the transabdominal scan, especially in a obese woman, thick abdomen, or thick abdomen, and or patient having concomitant like for a transvaginal scan is a low cost and non-invasive examination, and like I said, it can detect the DIE, deep infiltrating endometriosis, such as you can see the nodules or the endometrioma. Okay, this is the ultrasound finding endometriosis. Okay, we can see this is the ovarian cyst. Okay, you can see homogeneous low-level internal echoes giving pictures of ground glass appearance, and you can see with the posterior acoustic enhancement suggesting the endometrioma, and you can see also fluid level suggesting acute exacerbation, especially during post-menses. Okay. Okay, this is laparoscopy. Laparoscopic views of endometriosis. So the features of endometriosis from laparoscopic visualization is all the blackish spot is a powder burn of gunshot lesion over this one is the POD, pouch of Douglas. You can see like this one is superficial endometriotic lesions, and you can see this one also. This is like white lesion, okay, and a red lesion over the posterior part of the uterus, and you can see also this one flimsy adhesions over the posterior part of the uterus, in between the ovary and posterior part of the uterus with the fallopian tube. Okay, and this is the ovarian cyst. You can see the chocolate cyst from this picture. You can see the brownish stain from the ovarian cyst. This is the endometrioma, and you can see this picture, the POD, pouch of Douglas, already obliterated, and with sign of endometrioma addition, okay, flimsy, or maybe this one is like moderate flimsy and moderate addition with obliterated of pouch of Douglas. We can see this woman having severe endometriosis, and you can see also this one, the dense additions, okay, from the anterior part of the uterus, okay, with the with the UV fold. So you can see, so overstretch, it can it lead to scar and band formation. So in this type of patient, so we in this type of patient with addition, with bad addition and endometrioma, usually patient might having symptom of dyspareunia, severe dysmenorrhea, chronic pelvic pain, and also infertility. Okay. This photo is a normal reproductive organ. You can see this is the uterus, the normal uterus. You can see the normal, you can see, and also this is the normal ovary. So there's no superficial or deep infiltrating endometriotic spot. You can see this. But in this picture, you can see the uterus, okay, already like a bulky uterus compared to this one, bulky uterus. Maybe this patient had concomitant of adenomyosis, and you can see the fallopian tube and also the ovary. There's maybe the blackish spot is already patient having like superficial endometriosis. So this one is like minimal or mild endometriosis. Okay, this photo you can see uterus is like normal, the fallopian tube looks normal. Okay, the endometriotic spot over the posterior part of the uterus and also over the pouch of Douglas. So this maybe we can say that moderate, sorry, the mild endometriosis, because we can't see obvious addition mild endometriosis. In this photo, you can see all the blackish or the endometriotic spot, the blackish one, with you can see the orientations of the uterus or reproductive organ is already obliterated. You can see obliterated, and there's a lot of scarring and also a lot of thicken. You can see the thicken because of the chronic inflammation process happen, and thickening and also scarring and also dense adhesion with obliterated of the pouch of Douglas. This one is like severe endometriosis, and I think this one is the ovary being blanketed by the obliterated or being obliterated fallopian tube. Okay, this is like severe endometriosis because you can see clearly the plane like the above photo. Okay, according to classification of endometriosis, so the American Fertility Society revised classification of endometriosis. From the laparoscopic view, we can stage and classify the type of endometriosis. Okay, like I said, if minimal and mild, usually it just involves the superficial endometriotic tissue. You can see. Okay, with only flimsy adhesion. However, in a moderate stage of endometriosis, you can see the deep endometriotic tissue already implanted to the ovary and also at the pouch of Douglas or cul-de-sac, and with a dense already means moderate moderate classification. It already have a dense adhesions. Okay, with dense adhesion, so we can say this is moderate. With a scoring around 29 to 26 to 29. For the severe stage of endometriosis, so you can see there is presence of superficial and deep endometriotic tissue with dense adhesions. You can see this photo, dense between the fallopian tube. It adhesion between the ovary and also the fallopian tube, and adhered to the part of the ovary. Okay, and you also can see like this photo. Okay, you can see all the scarring formation and dense formation happen at the pouch of Douglas. Okay, POD. So by the advantage of laparoscopic visualization, actually we can stage the endometriosis and also to get the sample to send for to send tissue for the histopathological examination. And from this staging, we can consult patient, especially when patient presented with endometriosis with infertility. We can consult patients the prognosis of her current condition and the further action for the fertility treatment. And usually in a severe stage of endometriosis, you can see the tube also obliterated, and we can see that if the tube is already obliterated, it can affect the tubal functions of the woman. Maybe the tube already not functioning, means already being blocked by endometriosis. Okay, how about the biomarker for endometriosis? Okay. Usually CA125 is is no use measurement for endometriosis. Okay, just if we get the case, if patient presented with the ovarian cyst, so we need to take tumor marker. If from the ultrasound or from the radiology, we have suspicions of other pathology of ovarian cyst, okay, or to rule out any malignancy from any ovarian malignancy. So we need to take baseline of tumor marker, especially CA125. Okay, the management of endometriosis, we can divide into medical management and also the surgical management. So for medical management, so there's a few of medication that we can offer for the patient, such as if patient presented with a mild symptom of dysmenorrhea, so we can offer her baseline is NSAID. And if successful, I think we can just observe or treat conservatively. And if patient having persistent dysmenorrhea or chronic pelvic pain, or having chronic dyspareunia, so we can upgrade second line of medication such as hormonal contraception. We can offer progesterone pills. Okay, and other than that, we can offer also GnRH agonist and aromatase inhibitor. But aromatase inhibitors such as letrozole usually clinically used, meaning is still under study. Okay, to consider treatment for the patients, okay, we need to see the patient's preference and also patient medical background, having medical problem or the profile of the patient. Patient might have any allergy or what, so we need to. And also for the hormonal treatment, so we need to see also the side effect of the hormone and the efficacy and the cost of the patient, and also availability in your center. Okay, treatment of endometriosis, like I said, the first line is a progesterone inhibitor, or we can start with the NSAID. If success, then we just continue the treatment or conservatively. However, if we start NSAID, patients still not tolerable, still having persistent pain, then we can step up our treatment to the hormonal. Okay, hormonal like COCP or CPOP. Okay, and if the hormone or the medical treatment is failed, so we can offer for surgical management. Okay, the golden surgical management is laparoscopic. Okay, laparoscopic for proper for the diagnostic and also for the therapeutic. Okay, so this is the drug therapy for the management of endometriosis. NSAID is a mechanism of action is inhibit OX1 and OX2, so resulting decrease in prostaglandin formation, mean to decrease the pain. And for COCP and POP, it inhibit FSH and LH, lead to decreased cell proliferation and enhance endometrial apoptosis. Okay. Whereas the GnRH agonist, it will inhibit steroidogenesis, okay, and also inhibit the steroidogenesis. However, the GnRH agonist can cause a pseudo menopause to the patient, and the patient will having sign and symptom, means having a side effect of pseudo menopause, like hot flushes, vaginal atrophy, and bone loss. For the younger age, we might start GnRH with add-on therapy means we can add on with the low dose estrogen, progesterone, or tibolone to reduce the side effect of loss of bone or osteoporosis. Okay. COCP usually is benefit for dyspareunia, dysmenorrhea, and non-menstrual pain. And according to Cochrane review by Brown et al., so conclude that OCP was associated with improvement in self-reported pain, dysmenorrhea, cyclical non-menstrual pain, and also dyspareunia and dyschezia. Okay, this is Dynogest. Dynogest is a progesterone group which highly selective progesterone activity and known to be effective in the treatment of endometriosis. Okay. Okay, this is a study done by prospective non-interventional study done by Envision N. So by the study, you can see the impact of long-term Dynogest therapy on quality of life in Asian women. Okay, so majority of patients and physicians who satisfied that Dynogest reported improvements of endometriosis more than 80% of patients. However, the rate of there is a drug-related side effects such as vaginal hemorrhage, okay, metorrhagia, and also amenorrhea by taking the Dynogest. And also, Dynogest have a promising first-line treatment option for the long-term management of debilitating endometriosis-associated symptoms. Usually, they ask up to 5 years. However, if we want to further continue the Dynogest more than 5 years, so we need to reassess back the patient on side effect and all that. Okay, for the hormonal treatment, so the study done to show the benefit between the continuous and cyclical use of COCP. So from the study, so a systemic review and meta-analysis done by Muzi and colleagues compare continuous versus cyclical OCP to see the decrease in the pain tolerable or not with the continuous or cyclical. So the continuous regime appear to be more effective with regards to dysmenorrhea recurrence. However, there's no significant difference between continuous and cyclical OCP for the symptom of chronic period pain, dyspareunia, or to reduce the recurrence of cysts. Meaning to say, the continuous OCP will reduce with more efficient to reduce the dysmenorrhea. However, other pain, there's no difference in the CPP, chronic pain, dyspareunia, and the lowering recurrence cysts is not significant between continuous and cyclical OCP. Okay, this is study done by Su-Yan Park and team to evaluate the efficacy and safety of Dynogest in patients with endometriosis for the 12 months. So from this study, so pain was significantly reduced at 12 months, meaning they continue the medication for 1 year. So pain was significantly reduced after the Dynogest medication. Okay, in those treated with Dynogest due to recurrent endometrioma, okay, the size of the endometrioma was significantly decreased also at the 12 months to 18 months. Okay, meaning so Dynogest is significantly reduced for case endometriosis with dysmenorrhea and also endometrioma in reducing the size. So the study take about 12 months, means 1 year. However, there's a few side effects of Dynogest. such as frequent or prolonged uterine bleeding, okay, nausea, vomiting, weight gain, acne. Okay, sometimes patient having breast tenderness. Think the side effect is just like other progesterone, but still tolerable. From this study also, from the other study, show that sometimes patient stop taking Dynogest, not due to usually due to uterine bleeding. Okay. Okay, Mirena also one of the treatment of choice for endometriosis, especially patient with chronic pelvic pain associated endometriosis. And the Mirena so delivers significant amounts of levonorgestrel into the peritoneal fluid and clearing up the local effect on the endometriotic implants. So it can use for 5 years, and for women not plan to get not plan to conceive lah. Is long term. Is about 5 years. Okay. GnRH agonist. Okay. Usually, the GnRH agonist also recommended for patient with endometriosis associated pain. Okay. The mechanism of action is inhibit the secretion of FSH and also preventing ovarian production of estrogen, creating the hypoestrogenic state, means like pseudo menopause for the patient. And by this hypoestrogenic state, it inhibits the developments of endometriosis. Okay, usually we start the GnRH after we offer patients for the diagnostic laparoscopic results for confirmation of endometriosis, and then if already confirmed by the during the intraoperative and by the histopathological examination, so we can start post surgical, post laparoscopic. We can start the GnRH agonist for about 3 to 6 cycles to suppress the endometriosis activity, and then we need to counsel patient before we start the GnRH, because young lady, when we start the GnRH, we create a pseudo menopause for the patient, and then that patient might have having symptom of menopause such as insomnia, mood irritability, okay, vaginal dryness, and also risk of osteoporosis. Temporary means risk of temporary endometriosis, risk of temporary osteoporosis might happen. So we need to add on add back therapy for this patient. Usually we give about 3 to 6 months, then we reassess back the patient. Okay, what is pro and cons to start medical treatment? Okay, medical treatment, the pro is we can avoid risk of surgery lah. Okay, if surgery, you may have a risk of injured to the surrounding or neighboring organ, and also we can avoid the risk of post-operative addiction. And the pro is we can by medical treatment, we also can treat implant which was not visualized during the surgery. Okay, the cons for medical treatment is sometimes the patient can tolerate or not. We need to try to start the patient, and then we need to follow up to get feedback from the patient, that patient can tolerate or not, patient develop any side effect from the medication. We may change to the other medication, because a lot of OCP and POP in the market that we can change, or we can try to give to the patient just to adopt, just to reduce the patient's side effect. Okay, and also cons for medical treatment is once we stop the medication, sometimes the recurrence might happen. Patient might have having dysmenorrhea again once the medication stopped. And for the effect of, like I said, that in a severe, moderate to severe endometriosis, so when moderate or severe endometriosis, the reproductive organs of the woman already a lot of addition happens, scarring happen because of the chronic inflammation of the endometriosis. So by giving medical treatment, usually there's no effect because of the because of the obliterated or of the reproductive organ already happened. So there's the symptom like chronic pelvic pain, severe dyspareunia, and severe dysmenorrhea. Sometimes there's no response with the medical treatment, so might need to have to release the addition maybe. Okay. And also if patient already having endometrioma, so usually the medication to reduce size of endometrioma of ovarian cyst, sometimes no effect by the hormonal treatment. Okay. And if patients plan for fertility treatment, so we give a hormone such as OCP, POP, or GnRH agonist. So sometimes it can suppress the it suppress the ovulation, and the patient can be pregnant from once patient taking the hormonal treatments. Okay. Okay, what is the role of a minimal invasive surgery? Okay, if you already start your baseline treatment, medical treatment, but still patient having the symptom, or we call failed medical treatment, so we can offer for MIS. Okay, or if patients plan for infertility treatment, like I say, in a stage of severe endometriosis, we know that the patient, the prognosis of the patient to get pregnant or to conceive for MIS. Okay, or for patient with having a recurrent of endometrioma, so with a recurrent endometrioma, that symptomatic endometrioma. Okay, so we can offer also for minimal invasive surgery. And other than that, LUNA means while doing the MIS, minimal invasive surgery, we can offer her, or we can proceed for another procedure we call LUNA, which is laser uterosacral nerve ablation, meaning we ablate the uterosacral nerve to reduce pain for the patient during the MIS surgery. However, this procedure sometimes is not effective to reduce the pain also. Okay, so surgery for endometriosis is now reserved for women with a severe symptom. Okay, if a woman presented to you with a large ovarian cyst, symptomatic ovarian cyst, or to plan to get conceived. So the laparoscopic is the gold standard for diagnosing and therapeutic, as laparoscopic can compared to the conventional open surgery, in view of a less pain, less infection, okay, less additional inflammation, and fast recovery for the patient. However, for the patient with a recurrent endometrioma with multiple times of surgery, so we need to be more cautious. If patients still young, patients still keen for fertility treatment, in view of repeating endometrioma surgery, like we do multiple time of eviscerations, ovarian evisceration for endometrioma, or excisions of the endometrioma ablation, and also stripping of the ovarian capsule, may lead to the ovarian damage to the ovarian, or may lead to you may jeopardize the ovary from getting that woman to get pregnant, means will lead to the poor ovarian reserve. Okay, this is a prospective cohort study was conducted. Post-operative follow-up visit was scheduled after the laparoscopic excision of endometriosis, including the follow-up to check for the pain and for the recurrence endometrioma within 3 years post-operative. So from the study, the dysmenorrhea, dyspareunia, and chronic pelvic pain recur after 3 years, okay, about 14.5%, CPP about 5%, and the recurrence of the endometrioma about 9% after 3 years. Okay, so regarding Buska et al., so for recurrent endometrioma with proceed with recurrent surgery, risk of ovarian failure means the poor ovarian reserve and risk of ovarian failure might happen if the bilateral ovarian endometrioma removal. Okay, surgery in endometriosis. So elimination of endometriosis, we can do excision, okay, we can do diatemy, ablation. Ablation is we do some sort of additional lysis. Because of the additions, scar information, we release all the addition. So by doing ablation, and also division ablation, it aims to restore normal pelvic, near normal pelvic anatomy, okay, as what we can, and like I said, laparoscopic MIS, minimal invasive surgery versus open surgery. Usually, we opted for the we will opted for the laparoscopy because of the benefit, a lot of benefit like less pain, shorter hospital stay, and quicker recovery. Okay. So for the patient, we plan for surgery or we propose for surgery if the medical treatment fail or patient want to work out for fertility. So we need to counsel patient properly regarding the surgery itself, the operation, the nature of surgery, okay, the complication and the side effect from the surgery, and you need to counsel also the cyst recurrence might happen after the surgery. So, and maybe in the endometriosis, like in unlucky women, so they might have underwent multiple times of surgery, which may increase risk of increased complication and risk from the surgery itself. Because of the endometriosis is a chronic inflammatory process and it will continue, meaning if the woman still having the still in the reproductive age, is not menopause yet, so the risk of recurrent, the risk of the disease getting worse or getting severe is still there. Okay. Okay, this like I said, the surgical excision usually the surgery is we can recommend to patient the last resort because of the risk of the risk and complication from surgery itself. Okay, so we need to refer to the center which have expertise, especially in a minimally invasive surgery, and sometimes if in a difficult case, like in a severe case, we can refer to the center which is having a specific means the expertise, okay, having can treat the severe endometriosis in view of the complication. Okay, this is a surgery, the minimal invasive surgery. Like because we expect for the endometriosis a lot of adhesion, formation, scarring, and difficult surgery. So usually the proper step will be done to avoid the complication of patient might happen, such as bowel injury, uterine injury, okay, and bladder injury. So we need to properly counsel patient before surgery, and also in a very difficult case, sometimes we need to anticipate the neighboring organ injury by such as by doing like we put ureteric stenting prior to the surgery, and also we need to ask for the surgeon from the surgical team to stand by in case if having like very bad adhesion bowel, bladder and all that. So we might need help. From the surgeon for proceed the surgery. Okay, so for the endometriosis with infertility, usually, like I said, with the moderate to severe stage of endometriosis, because of the slim chance of getting pregnant spontaneously, so we usually will proceed. We usually recommend patient for the laparoscopic or surgical treatment prior to the assisted reproductive therapy for the better prognosis. Okay, sometimes we can clear up all the means we can remove the endometrioma. Okay, and also we can release the adhesion to get a near normal reproductive and anatomy and all that prior to the infertility treatment. Put on 3 to 6 month GnRH agonist to suppress the endometriosis, and then we embark with ART, assisted reproductive treatment. I think with this I end of this session. Thank you.
Thank you, Ma'am Azima, for the informative and interesting talk. Now I would like to welcome Lieutenant Colonel Dr. Rustini for her next topic, that is contraception for the planned pregnancy. Thank you, ma'am.
All right, thank you, Dr. Sandari. Assalamualaikum and good afternoon. So now my topic, contraception for the planned pregnancy. Okay, right. So it's a contraceptive, so this prevents the pregnancy. Okay, introduction. So all families can be planned effectively and safe. So there is a wide variety of contraceptive methods are available, even though in Malaysia. So we consider it's very effective if planning rate is less than 1%, PI less than 1, or highly effective if PI less than 0.5. Okay, so is I emphasize regarding thorough counseling, help ensure suitable and successful of method use. Okay, definition of family planning. Okay, definition is to decide numbers and timing of children in family. Okay, kita nak berapa ramai, berapa jarak, semua tu adalah definition of family planning. Okay, so we should know that family planning is a human right. It's not husband's right. It's not the client's right only. So they have to discuss each other. Okay, and also it's not doctor's right. Okay, so what is the best? Too close or too far? Okay, so the aim for the family planning, there's a few. Okay, first, to avoid unwanted pregnancy. Okay, and the second, we want to regulate the interval between pregnancy, and also to determine the number of children in family, and the fourth, to assure that resources for raising children are available. Alright, cukup masa, cukup social, financial support, and also environment. Okay, and the fifth, to improve health of mother and children, and the last but not least, to prevent STD and HIV. Okay, Imam Al-Ghazali berpendapat riset pengguguran kandungan adalah haram mutlak sekalipun pada peringkat awal, iaitu nifah, kerana ia asas kehidupan manusia. Namun, alright, beliau berpendapat bahawa azal adalah harus dengan beberapa niat syar'i. Antaranya, kita boleh merancang sebabnya faktor ekonomi, kesihatan isteri, kecantikan isteri, bagi tujuan kasih sayang berpanjangan antara pasangan, bagi mengelakkan talak. So Islam pun digalakkan untuk buat family planning, merancang keluarga. Alright, if you can feed your family, give them an education, then you are success. Baca methods. So increased access to contraception is directly linked to decline in maternal and neonatal mortality. So kita kena faham, we have understood our product, very known well with our product, so we can counsel diet properly. Kalau if there is no proper family planning, unplanned pregnancy or unintended pregnancy, this one dia punya consequences lah. Alright, so mother have a greater risk physical, mental abuse, later or no antenatal booking done, family disharmony relationship, economy may suffer hard, and also they can fail to give attention and education to their children. So there are contraception methods. Pilih mana satu yang mana sesuai, mana ikut hati yang berminat lah. So kita akan go one by one. Alright, mungkin saya akan cepat sebab masa mungkin tak mengizinkan lah, dan slide saya agak panjang juga. Alright, so how you choose your contraceptive methods? First, safe and effective. And second, tolerable side effect. Third, cost effective. And fourth, friendly administer and use. Number 5, require little or no medical supervision. And the last one, culturally feasible and acceptable. That's why how kita choose out the best one yang sesuai untuk diri sendiri, ataupun dengan klien kita, kan? Right? Contoh cost effective. Alright, mungkin klien ni tak sesuai dengan implanon, kalau harga dia terlampau mahal, kita boleh offer other method of progesterone only, kan? Begitu juga tolerable side effects. mungkin this client tak sesuai dengan Yasmin, so we can offer other method of COCP and friendly administer and use. Okay, mungkin klien ni dia tak sesuai untuk makan, takut lupa ke apa, so kita boleh offer yang injection. Okay, itu yang paling mudah untuk dia lah. Okay. Then culturally acceptable, adat. Okay, macam contoh alat IUCD, tak semua orang boleh terima, tapi itu sebenarnya paling bagi saya mudah lah. Alright, so we can classify our contraceptive method into temporary and also permanent. Alright, temporary consists of hormonal and non-hormonal. Hormonal ada two, estrogen, combined estrogen and progesterone, and another one progesterone only. Alright, you go to the basic pathophysiology because you want to know the mechanism of action. Alright, so you go see the graph. Right, we have ovarian cycle. Alright, the anterior pituitary, ovarian hormones, and anterior uterine cycles. Okay, so we consider daripada day one. For day one, and let's say we get a average menstrual cycle 28 days. Alright, so day one, these are menses. During that time, all the hormones are very low ataupun at the baseline lah. Even anterior pituitary hormones and also ovarian hormones. Okay. So anterior pituitary hormones they release the LH and also FSH. Okay, ovarian hormones release the estradiol and progesterone. Okay, once menses already habis semua. Okay, at the same time the ovarian follicle starting growth. Okay, which are hormone? Okay, hormone FSH, follicle stimulating hormone. Alright. So started increasing because they want to grow the follicle. Okay, right. So the follicle is growing. Right. Okay, during the ovulation. Okay, LH hormone also akan secreted. So ovulation occur. At the same time, hormone progesterone, alright, will increase after ovulation. Alright, because we are preparing for the thickening of the endometrium. Alright, if there is no implantation occur, so the endometrial lining will be shedding and menses again. So combine hormone estrogen and progesterone. Okay, so their action such as a feedback inhibition. Okay, alright. It can directly add to the anterior pituitary, and also it can add at the ovary. Estrogen, it inhibits the FSH. Right? So follicle development is reduced. At the same time, LH also inhibited by progesterone. So it inhibit the ovulation. Alright. At the same time, progesterone also inhibit the passage of the ovum. Let's say ada yang follicle not responded. Okay, so the berlakunya ovulated. Okay, so progesterone akan inhibit the passage of ovum. At the same time, progesterone also add at the cervical mucus, so they thicken the cervical mucus. Alright, so the sperm and also oval, cervical and the sperm and ovum not meet each other, and also the implantation not occur. Okay. Side effect, right? There's a side effect estrogen such as weight gain, bloating, breast pain, okay, headache, migraine, nausea, vomiting, and blood clotting, and also hypertension. The side effect progesterone, uneasy, lethargic, depressed, okay, irritable, fluid retention, okay, increased appetite, weight gain, breast pain, sometimes libido also low, and oily face, and also menstrual disturbance. Okay, we have to remind again, progesterone effect, menstrual disturbance. Okay, we go for the combined hormones. Okay, composition hormone, estrogen usually they use the internet estradiol EE, and the progesterone is either this one 1917 and also 70 alpha spironolactone derivative. Okay, so the progesterone there are few generation. Okay, the latest one is 4th generation. Okay, newer formulation, okay, dulu-dulu we have a high dose EE, okay, low dose progesterone, okay, but recently, okay, the amount of estrogen already reducing 1/5 and amount progesterone also already reduced 1/10, okay. Usually we have EE around 15 to 35, and then we have very selective progesterone. Okay, why? Okay, because it improve the tolerability. Very low suitable, the lowest dose suitable dose can provide effective contraceptive, acceptable cycle control, and also the side effect also low. That's why the rationale for the development of oral contraceptive. Okay, this one the generation of the progesterone. Okay, you can see, okay, the first, second, third, and fourth. And later I will show the table regarding all the CLCP yang ada di Malaysia. Okay, kenapa ada orang sesuai this one, ada orang sesuai this one, ada orang sesuai yang group D. Kalau we see the first generation, the side effect semua ada. Estrogenic, progestational effect, and also androgenic. Compared to the fourth generation, fourth generation, estrogenic and androgenic effect very memang tak ada lah, no cuma very mungkin ada sikit progestational effect. Okay. Okay. Sorry. Okay. CLCP. Alright. Failure rate around 0.3 to 8 per 100 woman year. So CLCP can consist either 21 pills or 28 pills. In 28 pills, 21 pills contains hormone, another 7 pills is placebo ataupun no hormone. Alright. So regarding the menses, okay, bleeding experience during free hormonal, right? And the flow is very shorter and lighter. Okay, very high effective if used correctly. 0.3 kalau kata perfect use. Okay, alright. So benefit dia easy, reversible, kita senang anytime boleh off. No acne, okay, improving acne, kulit lagi cantik, okay. And also can ada benefit reduce risk of endometriosis or ovarian CA. Non-benefit management of abnormal uterine bleeding, PCOS, and also can reducing functional ovarian cysts. Alright, these are all COCP available in Malaysia. Loet, Rogividon, Nodec, Oracon, Mercilon, Marvelon, Rugulon, Yasmin, also Diane. Okay, yes. They have a 28 pills. Yasmin kita dah biasa dengar. Alright. Diane 35 or ST 35 usually we use to treat women with PCOS. Okay. Because they are fourth generation, so they akan specific. At the time they can treat the hirsutism. Cuma dia punya dose EE dia agak tinggi lah compared ada COCP yang lain. Alright. So kita boleh tengok lah which one yang akan sesuai dengan pesakit. Kalau kita nak effect dia, estradiol effect dia lebih, mungkin kita boleh choose yang ada 30 EE lah, microgram. Okay. Kalau kita nak dia reduce the side effect more tolerable, mungkin choose progesterone punya apa tu group, generation third or fourth. That's why kalau kita tengok ramai yang kata dia suka Yasmin. Okay, sebab Yasmin fourth generation progesterone. Okay, so dia punya selain daripada very good for the extra benefit other than as a contraceptive, okay, dia punya kulit cantik lah. Tak ada jerawat, no weight gain kan. Alright, compared the others. Okay. Okay. Miss-pill management, apa kita nak buat? How you counsel patient kalau dia tertinggal ubat apa semua. Alright. So we know, okay, our pill have 21 tablets, okay, or 28. Kita ambil senang 21 lah. Alright. So we divide 3 weeks, okay. Alright. Kita divide 3 weeks, first week, second week, and third week. Okay, let's say we miss pill on the first week. Alright. So terlupa, kita ambil terus. Terlupa, straight away, ambil dia, the miss pill, okay, continue as usual, but, okay, kita ada extra precaution. Extra precaution for the next 7 days. Extra precaution, either you can use a condom ataupun abstinence, tak bersama langsung. Okay, maybe you can offer emergency contraception lah kalau there has been unprotected sex lah. Itu first week kalau terlupa. Second week pun kalau misfire on the second week, alright, so we straight away taken the misfire and continue as usual, but again extra precaution, either condom or emergency contraception for the next 7 days. Okay, alright. Okay, the first week, the second week lebih kurang sama je, but the third week, miss during the third week. Okay, so straight away take the misfire, okay, continue as usual, tapi kita akan habis third week pill, kita continue the next pack. Maksudnya no free. Kita tak ada free. Habis je pill yang day 21, alright, we continue the new pack. Okay, no extra precaution, tak perlu, cuma kita continue je pack yang baru. Okay, alright. Alright, next is Novary atau January. Okay, failure rate about 0.3 to 9 per 100 women year. Okay, Novary ni is not available in our setup. In Malaysia pun saya rasa tak ada, saya tak nampak mana-mana kongsi. Tapi saya pernah tengok masa tahun 2010 tu kita pernah tengok lah, and then offer, tapi because of again culturally acceptable tu kurang, jadi dia tak dapat permintaan yang tinggi. Okay, so Novary the content 50 microgram EE and also third generation of progestogen. Okay, release per day. Very flexible and small ring, about 2 inch. Okay, silicone. Okay, alright. So kita akan insert the vaginal ring daripada day 1 until day 21 for 3 weeks. Okay, so day 20 tu kita remove and then free untuk 7 days, and then day 8 tu reinsert balik yang baru. Sama macam pill, cuma yang ni kita insert through the vagina lah. Kita masuk through the vagina. Very flexible, senang yang masuk. Okay, has enough hormone reservoir, can be removed up to 3 hours without loss of efficacy. Let's say not consume the sexual activity. Okay, so they can remove the vaginal ring, consume the SI, then after within the 3 hours kena reinsert balik. Kalau kata delay more than 3 hours, okay, dia punya effectiveness tu akan reducing. Alright, so dia kalau nak compare dengan COCP, alright, efficacy, tolerability sama saja, cuma better compliance, tak perlu ingat hari-hari kan. Dia punya cons dia, no STD protection, not effective for obese women sebab okay, EE punya content very low. Alright, so we go another transdermal page. Okay, sama je failure rate macam Novary, 0.3 to 9 per 100 women year. Okay, dia senang je. Kita boleh dia patch, okay, they contain 20 EE and also fourth generation of progestogen. Alright, so you can patch at buttock, abdomen, outer upper arm, and also upper torso lah. Okay, so letak situ for 3 weeks, okay, weekly, and then 1 week free patch. So better compliance, but this is constant no STD protection, and then for allergic skin and not suitable for obese women. Alright, okay, then we go for the progesterone only. Alright, progesterone only, again, I emphasize there is a few generation. Okay, of course, okay, kalau tanya, saya akan choose generation yang keempat lah, sebab mungkin the side effect is less and kita more tolerable. Okay, so we go for the POP, progesterone only pill. Alright, failure rate 0.3 to 8 per 100 women per year. Dan 1 tahun 100 orang woman, 1 orang perempuan yang ambil POP, mungkin 0.3 atau 8 orang yang akan fail lah. Alright, jadi it's suitable for lactating women, heart disease, okay, who has history of BTE, smoker, so kita offer lah dengan POP. Alright, so lagi bagus POP ni dia free pill. No free pill. Continuously taking. Okay, habis satu packing 28 biji tu sambung terus. Okay, mechanism of action. Alright, the tickle cervical mucus within 48 hours. Alright, and also detaining the endometria and also suppress ovulation. Cuma dia punya side effect, masalah dia adalah menstrual disturbances lah. So your menses, the menses can be amenorrheic, irregular, spotting, prolonged spotting. So that's why kita kena remind our client lah, okay, apa masalah dengan POP ni. Okay, so our setup we have two lah POP. Yang biasa dah glamour biasa guna adalah Noriday. I think all subtopic memang ada Noriday. Okay, so Noriday second generation dia ada pada norestestoron 250 microgram. Okay, another one is Cerazette. Okay, Cerazette dia ada third generation, dia Sogestrel 75 microgram. Okay, so bagusnya Cerazette dia punya action dia menyebabkan end ovulation nanti 7%. Okay, side effect lebih kurang sama. Okay, cuma keberkesanan tu Cerazette tu end ovulation lagi tinggi. Another one, the window period. Okay, Noriday kita akan remind our client, okay, puan jangan lewat makan lebih daripada 3 jam. Okay, tapi dengan Cerazette kita boleh cakap dengan klien jangan lupa makan ubat ni lebih daripada 12 jam. Okay, so in terms of compliance maybe better for the Cerazette kalau terlupa kan, especially bila nak makan waktu malam. Breastfeed the baby memang ibu-ibu akan mengantuk semua. Bangun-bangun dah lebih 3 jam. Itu masalah dengan Noriday. Kata saya makan ubat doktor, tapi mengandung macam mana? So kalau dengan Cerazette, mungkin dia dah menyusu anak, penat-penat letih ataupun dalam menyusu anak memang akan tenang, akan tidur semua. Kalau dia terjaga, dah lebih 3 jam pun masih okey lagi. Janji kalau dengan Cerazette, jangan terlewat lebih daripada 12 jam. Okay. So kalau terlupa juga apa nak buat, okay. Noriday, kalau terlupa ambil Noriday, kita dah lewat ambil lebih daripada 3 jam pada waktu biasa. Okay. So kita ambil dos yang terakhir, ambil serta-merta. Okay. Hanya satu pil saja. Contohnya kita biasa makan pukul 9 malam. Okay. Tiba-tiba terbangun sebab dah tertidur pukul 3 pagi, 4 pagi baru terjaga. So dah lebih 3 jam. Okay. Kita ambil tu pil yang terlupa itu. Dan the next day tu kita continue macam biasa. Cuma memang sebab dah terlewatkan makan, jadi kita kena ambil extra precaution selama 2 hari. Okay, ataupun ambil emergency pill lah kalau nak bersama juga. Kalau dengan Cerazette tadi, okay, kalau dia terlebih lupa makan lebih daripada 12 jam, okay, so kita ambil pill yang terlupa serta-merta dan continue macam biasa. Alright, pun sama extra precaution untuk 2 hari ataupun ambil emergency pill. Okay. Right, so POP, extra precaution, okay, emergency pill kita boleh ambil dalam tempoh 2 hari ataupun lebih senang yang bersama 2 hari. Sebab kita nak bagi ubat tu jadi efektif balik semula. Itu kalau progesterone only. Kalau yang combine hormone tadi 7 hari kan, 7 hari extra precaution. Tambah sikit. Okay, so next adalah progesterone injectable ataupun senang ingat yang paling common yang glamour kita panggil depo injection, depo. Okay, failure rate 0.3 to 6 per 100 women year. So depo bagus dia inject memang sakit, tapi 3 monthly lah. Dia ada 2 jenis, dia ada 2 jenis, sama ada yang glamour depo provera. So for 12 weeks, okay. The other one usually in GP dia akan guna norestestoron acetate inhibitor for 8 weeks lah. So mechanism of action sama, the ovulation effect. And then endometrial alteration dia akan jadi very thin and also cervical mucus thicken. Side effect again kita emphasize regarding the menstrual disturbance. Okay. If you compare the norestestoron dengan depo-provera, okay, norestestoron dia punya menses disturbance tu less lah compared to depo. Kita nampak depo ni first generation sebenarnya. Noradrenaline adalah second generation. That's why we nampak kat situ kan. Alright, next implanon yang semua orang suka kan. Okay, so implanon very effective, 0.05 per 100 women per year. Okay, perfect use kalau kita pasang pada klien yang memang confirm tak mengandung. Okay, memang confirm tak mengandung, perfect use 0.05 per year. Okay, kalau kata tiba-tiba ada yang mengandung tu sebenarnya dia dah mengandung. Mungkin UPT dia belum naik positif apa semua, dia dah mengandung, pasal implanon dan kita tahu dia mengandung lah. Tapi kalau dia confirm tak mengandung, kita insert implanon, insyaAllah dia akan kekal 3 tahun kat situ, not pregnant lah. Okay. Alright, so implanon dia etonogestrel 68 mg, dia third generation, so dia pun slow release. Okay, every year dia punya release tu berbeza. Okay, dan dia high dose jugalah untuk suppress ovulation by inhibit the LH. In case ada juga patient kalau by clinical study implanon not associated with increased weight gain, tapi kalau comparable obese client and non-obese client, obese clients tend to increase the weight compared non-obese. Bila nak remove, tengok tak jumpa, kalau tak jumpa. Okay, so recent punya yang implanon memang dia akan replace barium sulfate. Jadi so kalau kata kita tengok patient datang, doktor, saya dulu pasang implanon tapi sekarang saya tak rasa. Kita nak buka pun rasa-rasa tak rasa. Jadi X-ray, kita boleh buat X-ray, so nak tengok dia punya position of implanon kat mana sebenarnya. Itu pun membantulah. Kalau dulu punya implanon dia tak ada barrier, dia susah jugalah sampai kita pakai ultrasound guided apa semua. Tapi recently dah ada, jadi senang kita nak X-ray tengok berapa dalam implanon dia pergi. Okay, alright. So another one, hormone releasing intrauterine device, okay, right, 0.2 per 100 women year. Ini tadi Dr. Cik ada terangkan pasal Mirena, dia progestin lah. Okay, Lenovogestrel second generation, 200 microgram per day, dengan dia ada total 52 untuk 5 years lah. So very high per index 0.1 to 0.2. Mechanism of action dia menyebabkan they can cause the endometrial atrophy, nipis, okay, and also thicken the spicules. So menstrual reduction, menstrual blood and bleeding inflow. Tapi kebanyakan Mirena ni digunakan untuk treatment lah, treatment for endometrial bleeding. Kalau untuk as kontraseptif ni boleh tapi jarang guna sebab Mirena ni agak mahal lah. Lebih kurang 800 ringgit Mirena. Okay. Kalau risk of uterine perforation and dislodge tu memang ada tapi very low lah, low incidence. Okay. Right, so we compare all the hormonal contraceptive methods. Kalau kita tengok paling tinggi very effective adalah implanon, followed by Mirena, Depo, COCP, POP. Okay, transdermal dengan vaginary macam our culture is macam kurang sikit nak menerima, jarang ada. Even kalau nak tanya pengusi pun tak semua pengusi yang ada. Okay, tapi kalau ikutkan, kalau everyone is perfect use, okay, semuanya memang akan very effective lah. Okay. Okay, so we go for the emergency pill. Okay, so emergency pill ni we include the hormonal lah, hormonal pill. Okay, the failure rate 0.1 per 100 women per year. Okay, there is 3 emergency pill. Okay, familiar in pharmacy, there is 2 lah. Okay, emergency pill used to prevent pregnancy after sexual intercourse. Okay, so we use within the 72 hours to 120 hours. Okay, so mechanism of action to prevent or delay the ovulation, but not induce the abortion. Kena faham kat sini. Okay, yang paling popular adalah antara 2 lah. Selalu saya rasa farmasi saya nampak dengan Prostino. Prostino ni adalah progesterone lah. Single dose, dia ada single dose ataupun divided dose. Kalau kita tengok sini ada 2 biji. So ambil 12 hourly untuk 1 hari. Okay, so kena ambil within 120 hours. After SI, anda boleh consume lah. Tapi after 5 days baru teringat, dia dah tak efektif. Itu juga dengan Elawan. Elawan is polycrystal acetate lah. So dia single dose of 30 mg. So after SI, terus ambil and then not more than after 120 hours. Because they are very high dose, okay, so again the side effects biasanya memang akan loya, pening yang sangat lah. So kita boleh je advisable kalau kata tak tahan standby Mezolone. Okay. Another one method is panggil USP method. Okay, USP method is OCP. Okay, biasanya USP method we use dekat hospital yang mana kita attend case yang OSCC lah. So they contain 2 doses. Okay, they masih a combination of EE kena 100 microgram EE campur plus dengan 0.5 mg of levonorgestrel lah, 2 hours apart. Contoh Nodate. Nodate ni dia contain 30 EE dengan 0.15 mg. So kita akan ambil total nak dapatkan 100 tu lebih kurang 4 biji. Baru kita akan capai USP punya regime ni. So patient makan terus. Tapi yang ni, okay, yang USP method ni dia berkesan very effective kalau the event less than 72 hours. Okay, so especially yang macam biasa yang saya tengok case ni adalah macam break case yang pergi OSCC. So kalau fresh case, okay, kita bagi USP method. Okay, alright, side effect nausea vomiting. Okay, if vomiting within 2 hours, so kita kena repeat balik. Sebab nanti ubat-ubat tu semua tak serap lagi kan. Jadi tak efektif. Jadi make sure kalau nak muntah pun lepas 2 jam tu barulah boleh muntah. Tapi kalau muntah kena ambil balik lah. Ataupun prepare siap-siap dengan Mezolone. And then not advisable, frequently used but it can cause the menstrual irregularity. Okay, so we see the effectiveness compared L1, prostatinol and also USP. Okay, so yang ni time between okay less than 120, okay, cuma USP dia less than 72 hours. Pregnancy rate lebih kurang sama, cuma USP lah. Saya rasa mungkin kadang-kadang kita tak dapat region yang betul that's why dia punya pregnancy rate lebih tinggi sikit compared the others lah. So begitu juga preventive pregnancy. Yang penting masa bila nak ambil emergency pill tu. Okay, kita go for the non-hormonal. Why I switch to non-hormonal birth control? Okay, alright. This one the common kita dengar kan ICD tapi still not bukan dalam kata pilihan hati, iaitu ICD. Right? Kalau tengok failure rate dia 0.6 to 0.8 per 100 women year. Okay, so non-hormonal so can as a contraceptive protection for 3 to 5 years. Recently ada yang juga 10 years lagi senang. Okay. Cuma in our klinik pakar sama ada 3 hospital rendah Mizan Lumut nanti kita guna yang 5 tahun lah. 3 tahun ni kita jarang tak ada dah. Okay. So mechanism of action dia akan create toxicity environment and prevent infiltration. At the same time dia akan thicken the cervical mucus to prevent entry of the sperm. Okay. Per 6 months mungkin akan dapat heavy menstrual bleeding. Okay. So kena remind juga patient lah, klien yang ambil yang guna IUCD. Okay. Nak risk of operation pun 1000 women maybe 2. Even though they dislodge. So kena beritahu patient. Bagus dia macam it's a very advisable especially for the army personnel kan. Terutama kait dengan weight gain. Jadi yang ni paling sesuai. Dia tak akan confirm tak akan naik berat badan klien kita. Okay. And then dia tak ada pening, tak ada loya, tak ada systemic effect and still can breastfeed the baby kan. So kalau saya tanya my personal opinion, okay, I love the IUCD. Okay, other natural method can be calendar, coitus interruptus, okay, lactational MR method and also condom. Okay, what is the best? Okay, natural method ni, of course free lah kan, tak payah susah-susah, free saja. But kena fully commitment, share responsible, and again no side effect. Tak ada side effect chemical, tak ada side effect mechanical, so natural je. Kita guna apa kaedah? Merancang sendiri. Natural, sebut natural tapi tak tahu apa itu natural. Okay, so pertama kita can use the calendar method. Okay, the failure rate quite high, 40 per 100 women per year. Okay, so nak guna calendar, how use the calendar method? Make sure your menstrual cycle is very regular lah. Okay. at least 6 cycle, regular menstrual cycle. Okay, so kita nak kira when the ovulation period, very fertile period tu. So that time, okay, voluntary abstinence. Okay, there is two lah, can calculate the cycle. For example, we take the shorter cycle. Okay, macam for example, cycle of 26 yang paling shortest, and the longest is 32. Okay, so shorter cycles minus 18, so you can get the day 8. Okay, the longest cycles day 32 minus 11, so you get day 21. So abstinence between day 8 to day 31. Contoh yang macam tu. Tapi kalau malas juga nak kira, susah, kita guna apps menstrual calendar. Okay, contoh this one on November 2020. So first day on 18 November. Alright. Okay, so dia memang ada regular cycle 35. So by apps they estimate the fertile period on the day 17 to day 23. Okay, so nampak yang pink-pink ni semua abstinence lah. Kalau tak abstinence pun apa tu kita boleh guna emergency pill atau ada kaedah yang lain kita akan terangkan selepas ni. Okay. Alright, so other than that, menstrual kita boleh buat cycle cycle. Okay, kalau kita tengok masa menstruation, after menstruation dah habis, kita akan dah vagina akan quite dry. But during the fertile period ni, okay, right, dia start dengan ada sticky, discharge, and then clear egg white, and then sticky. During ni adalah fertile period. Okay. So very fertile bila kita boleh nampak yang macam clear egg white tu. Okay, initially sticky and then clear egg white and then dia sticky balik. Okay, that one fertile. Kalau kata nampak dry, dah habis lah tempoh ovulation tu. Okay. Ataupun another one, kita measure the body vessel temperature. Okay. Sebab tadi kalau kita tengok balik pathophysiology, okay, progesterone akan increase after ovulation ni kan. Alright. So progesterone tu sendiri dia akan increase our temperature sikit lah. Okay. Kita akan ambil ada temperature ni usually every morning. Okay. Every morning. Jadi macam contoh kita tengok table pregnant chart ni, okay, every morning, alright, dia chart the temperature, tapi during the ovulation dia akan spike. Kalau sebelum ovulation dia bawa je baseline. Kita kena ambil satu baseline temperature lah. Tapi bila during ovulation dia akan spiking sikit. Tapi if you are pregnant, so the temperature akan sustain lah. Kalau non-pregnant child, okay, during ovulation dia akan increase. But bila if she's not pregnant, the temperature akan go down. Itu beza dia. Jadi kalau orang dia biasa dah hari-hari monitor dia punya body vessel temperature, boleh nampak bila waktu badan dia tinggi sikit lah. So kalau dia dah biasa, boleh tahulah waktu dia very fertile. So dia akan avoid that time lah. Okay. Paling senang adalah dia lah abstinence. Jangan bersama. Okay. Paling safe lah. Alright. Okay, kondom. Okay, kondom dia punya failure rate quite high also, 5 to 20 per 100 women year. Okay, so saya banyak cakap, kita dengar sikit pasal video ni, sebab kita kena explain to the client betul-betul. Kalau salah explanation, orang tak faham. Sebab again, our culturally, penerimaan tu macam mana, ayat pun salah. Ada orang boleh menerima, tapi ada juga klien tak faham. Okay, yang atas besar ni adalah kondom, female kondom. Okay, this one yang bawah ni adalah male kondom. Okay, kita dengar sini sekejap.
Bunting, saya pun dah sama nak pakai.
Saya rasa video macam ada tu. Ya, saya try balik. Tapi kalau kita assume every couple tu faham apa yang kita nak sampaikan, memang tak kita punya penyampaian tu tak sampai lah, especially even the condom. Okay, alright. If you don't use a condom, 1 + 1 dia akan jadi equal to 3. Alright. So other than that, coitus interruptus lah. Okay, coitus interruptus also like sama juga macam kondom. Okay, failure rate 5 to 20 per 100 woman year lah. Okay, so again this free and immediately available. Tapi kena full commitment and good self control and well experienced. Disadvantage, unsure able to withdraw before ejaculation. Ni susah sikit lah. Sebab kita tahu bila nak keluarkan apa semua, sometimes kan terlepas juga lah, terlepas juga the sperm into within the vagina. Against the no STD protection. Okay, alright, we go for lactational amenorrhea method LAM. Okay, about 0.5 to 200 woman year lah. So lactational amenorrhea period is effective for those yang exclusive breastfeeding. Only breast milk, no additional formula milk. Okay, lagi kerap more frequent breastfeeding, especially at night, amenorrhea just and effective only for the 6 months. Okay, after 6 months, okay, dah no effective for the LNM. Why? Sebab biasa after 6 months baby kita dah introduce makanan tambahan. Okay, alright, the last one is permanent method. Okay, permanent method, okay, either kita boleh buat untuk ladies kan, kita BTL, bilateral tubal ligation. Okay, usually kalau during cesarean kita akan terus tie and kite. This one a method. Okay, usually kita guna during cesarean. Okay, kalau electively bilateral tubal ligation, okay, usually kita guna clip. Dulu-dulu ada juga pakai pellet rim macam ni, banded. Tapi sekarang ni commonly kita akan guna clip, facial clip. Kita akan letak clip kiri dan kanan. Okay, this one for female. Kalau male sterilization, okay, they do the vasectomy under LA. So ni kena kiri dan kanan. Okay, dah a few even dah cut, okay, dia tak boleh bersama lagi. Okay, dah ada timing dia sebelum untuk bersama semula. Sebab dia nak habiskan yang mana sperm yang tertinggal, terutama ada tinggal dalam urine. Alright, I think for healthy babies and mothers, not too early, not too old and not too close. Jadi jawatan kuasa takdika kebangsaan bagi penyiasatan kematian ibu, so they recommend jarak kehamilan disyorkan adalah 2 tahun. Jadi mak sihat fizikal, mental, fisiologi dan sosial ekonomi. Alright, any questions?
Thank you, ma'am. Thank you, ma'am. We have 2 questions. The first one is maximum frequency to take emergency contraception. What's the maximum frequency, ma'am, in a month that boleh dengar ke, ma'am?
Frequency maximum 2 kali, twice per cycle.
Per cycle, ma'am.
Per cycle twice. So kalau tak dia taking more than that, dia akan dapat menses irritability lah.
Okay, ma'am. Ma'am, the final question is, we in ONG usually, like how ma'am said kan, my favorite is always IUCD, betul kan, ma'am? So we always, we counsel patient for IUCD. The first thing patient afraid is dislodging of IUCD, especially the grand multipara. So how, ma'am, we choose the criteria for IUCD insertion?
Okay. So again, incidence of ICD discharge pun in 1,000 women, only 2.
Okay, ma'am.
So kita kena reassuring the patient, okay, jarang benda ni berlaku. Unless even the grand multipara pun mostly grand multipara kan kata kita tak bagi pakai ICD. Kita boleh try and error lah.
Okay, ma'am. Tapi usually kalau it's already dislodged once, then
no.
we go for a different method, right, ma'am?
Yes.
Okay. So far, that's all the question that I got from the viewers, ma'am. Thank you so much for this informative talk. I hope our doctors in Papat Resat will counsel the patient for contraception with ma'am's fruitful information. Thanks, ma'am.
All right, thank you.
Now I would like to invite Dr. Azima again for her next topic, VTE prophylaxis. Thank you, ma'am.
Okay, thank you, Major Sanggari. So we proceed with venous thromboembolism prophylaxis. Okay, so like we know, VTE remains the leading cause of maternal mortality in the world. Okay, and the risk of antenatal VTE is 4 to 5 times higher in pregnant women compared to non-pregnant. Okay, and also the risk is higher within the first 3 months postpartum, is about 20 to 60 fold increase. Okay. And 90% of women who develop PE, pulmonary embolism, in pregnancy have identified risk factor. Okay, so therefore screening for the risk factor is a paramount importance in prevention VTE in pregnancy. Okay, and 1/4 of women with untreated or undiagnosed DVT will develop pulmonary embolism, and up to 15% can be fatal, and 2/3 of death occur within 30 minutes of the embolic event. Okay, so this is a pathophysiology of venous thromboembolism. So like we can see here, the Virchow's triad, there's 3 conditions predisposed to thrombus formation, which is hypercoagulability state. Okay, hypercoagulability state means our blood is easily get clogged. Okay, in a patient having either hereditary or acquired state. Hereditary means factor, like in a factor 5 leading, prothrombin G2, G2021-0A, and deficiency of protein C and protein S. Okay, and endothelial damage. Okay, such as in endothelial dysfunction, like in patient having hypertension or patient having surgery, undergone surgery, okay, trauma. And also the third one is stasis, means the immobility. okay, such as inpatient with ward admission in the ward, immobile or bedridden for few days in ward. So it can cause blood stasis and can clot and can contribute to VTE. Okay, like in pregnant lady, once the woman get pregnant, so it activate a clotting cascade and increase procoagulant activity, and in hemodynamic aspect, increase pregnant lady increase plasma volume and increase blood pressure, and also venous stasis. You can have venous pooling and the pelvic the gestation, the enlarged gestation, or the baby itself, the enlarged gestation, the uterus, the big uterus, we compress the pelvic vein, which can cause lower limb venous stasis, and also immunomodulatory aspect, increase dysfunction and increase cytokine surge, which lead to venous thromboembolism. Okay. Okay, this is acquired factor contribute to VTE. Okay, cancer. Other than that, it's cancer, chemotherapy. Okay, OCP and HRT. Okay, because hyperestrogen cause increased hepatic stasis of procoagulant protein, and also decrease synthesis of anticoagulant and fibrinolytic proteins. In a pregnancy and postpartum, high estrogen stasis, okay, and immunomodulatory lead to VTE. Central obesity, okay, mechanism include procoagulant effects of adipocytokines, okay, such as adiponectin, okay, increased activity of coagulant cascade, increased inflammation, oxidative stress, and endothelial dysfunction. All okay, this is actually for the antenatal, intrapartum, and postpartum. For pregnant lady, this chart is very important for risk assessment of risk assessment for venous thromboembolism. Okay, so we can see here my left hand side is antenatal assessment, and my right hand side is a postnatal assessment. Okay, we see first at the antenatal assessment. Okay, during booking we need to check. Okay, we need to check and we need to screen for the risk assessment each pregnant lady. Okay, the high risk is we need to get history from patient, or we can get previous the need of to check from the previous pink book to check for the previous obstetric and gynecology risk for this patient. Sometimes can give you information about the risk of VTE, such as patient previously having had history of venous thromboembolism before because of the pregnancy itself, or during the pregnancy, or during the postpartum. So that one, if patient pregnant, this current now patient pregnant again, so meaning patient is high risk. Okay, patient require prophylaxis low molecular weight heparin since as soon as possible up to 6 week postpartum. Okay, and you can if patient need admission, require admission for any other reasons such as hyperemesis or what, okay, that is a the transient risk factor. Okay, we need to consider patient as intermediate risk if patient had single previous VTE related to major surgery. Okay, means patient underwent any surgery, then patient end up having VTE. So that one is intermediate risk. Okay, if from the blood screening, patient had thrombophilia positive. Okay, so that one also intermediate risk. Okay, or patient having any medical comorbid such as cancer, heart failure, or patient pregnancy with underlying SLE. Okay, inflammatory bowel disease, inflammatory polyarthropathy, nephrotic syndrome, okay, type 1 diabetes with nephropathy, sickle cell disease, or currently patient is IVDU. So that one is intermediate risk. So we need to consider antenatal prophylaxis with low molecular weight heparin. And also, if a patient taking any like patient pregnant and end up patient having complication from OHSS, OHSS also will contribute risk of venous thromboembolism. That one also we need to consider low molecular weight heparin. Okay. Other risk factor we need to assess patient once patient presented to us. Actually, the VTE every time, every antenatal checkup, every session of antenatal checkup, we need to reassess patient according to the patient condition and according to the patient profile, such as BMI. So we check whether patient obesity or not. Okay, BMI is more than 30, age factor, okay, age more than 35, parity more than 3, is it patient smoker or not? Okay, and we check for any gross varicose vein and any current problem, antenatal problem that patient having, preeclampsia, or patient is immobilized or bedridden. So any family history of unprovoked or estrogen provoked VTE in first degree relative means from the history taking, patient, any family history from the patient having VTE or not. So we need to screen and get so patient will end up with VTE throughout the pregnancy or postpartum. Okay, and like multiple pregnancy or twin pregnancy also contribute to risk of VTE. And IVF or ART, sometimes during the assisted reproductive treatment, a lot of medication we use. So, and then sometimes the medication also can contribute to venous thromboembolism. So, antenatally, if 4 or more of these risks that you assessing during the antenatal checkup, so we need to start the prophylaxis since first trimester. Okay. However, if we get 3 out of others, at least 3 risk factor, so we need to start the low molecular weight heparin or VTE prophylaxis started from 28 weeks gestations. So I give you example, maybe this patient, this 40 years old lady, okay, gravida 5 para 4, currently looking at your clinic, okay, at 10 weeks gestation. She, her BMI is 40 with current condition, with twin pregnancy, and she is a smoker. So it means she had age factor is 40, obesity, now the BMI is 40, so 2 score. So the parity is patient gravida 5 means another score, and then patient is having twin pregnancy. So 4 risk factor out of the rest, means we need to start this patient on a low molecular weight since first trimester up to postpartum. Okay. So other transient risk factors such as dehydration, hyperemesis, or patient current systemic infection, or patient need to have a long distance flight travel. So sometimes we reassess back other risk factor also. If she had other risk factor which intermediate risk or other risk factor, then we need to consider low molecular weight heparin. But if no, so it's considered lower risk, and we just advise to the patient to get mobilized, drink plain water, means drink a lot of water to make your body dry. So make sure your body hydrate, so to prevent the venous thromboembolism. Or you can advise them to use anti-thrombotic stocking, anti-embolism stocking, okay, or TED stocking. So from this postnatal assessment, okay, same, we need to reassess, usually intrapartum and postpartum. Before we allow patient to discharge, we need to reassess properly the risk of venous thromboembolism, because the risk of venous thromboembolism is more higher compared to antenatal. It's about 20 to 60 fold compared to during the pregnancy time. Okay, like previous VTE or high risk of thrombophilia. So this one is a high risk, and patient need prophylactic low molecular weight heparin up to 6 weeks postpartum. Okay. If patient having a cesarean section, okay, post cesarean section, BMI more than 40, okay, patient maybe require readmission or prolonged admission, more than 3 days stay in ward, okay, maybe more than 3 days, just immobilize, okay, any surgical procedure in the puerperal aspect, immediate repair of the perineum maybe, okay, or patient have underlying or concomitant medical comorbids such as we already mentioned before, like anti-SLE, IBD, nephrotic syndrome, type 1 DM with nephropathy or sickle cell disease. So that one is considered intermediate risk. So we need to at least to continue the low molecular weight heparin postpartum about 10 days. Okay, if let's say if the woman had persistently more than 3 risk factors, so we might need consider thrombophlebitis with a low molecular weight. Okay, like other risk factor. So like age factor, obesity, again lah, we repeating again the same risk factor that we need to screen or we need to be assessed properly. The age, BMI, parity, smoker, whether patient having elective seizure, family history of VTE, thrombophilia, of course, varicose vein, or patient had current systemic infection, okay, current preeclampsia, okay. So all this might contribute. We consider postpartumly the intermediate risk, at least prophylactic low molecular weight about 10 days. Okay, like a prolonged labor. We use instrumentation like mid-cavity rotational or operative delivery, or patient having PPH. This one we might consider as intermediate risk, and at least to consider low molecular weight for 10 days. Okay, this one I think the previous chart, the previous chart is repeating the same. So assessment of VTE, if the score, like I said before, previously, the score is 4 or more antenatally, to consider prophylaxis from the first trimester. Okay, if the total score antenatally 3, okay, consider thromboprophylaxis start from third trimester, 28 weeks. And if total score more than 2 postnatally, consider 2 or more to consider this, okay. And then if admitted to hospital for about more than 3 days, immobilized, so we need to consider prophylaxis such as in a severe hyperemesis gravidarum, okay, patient having fever, so more than 3 days, so we need to consider. Or if prolonged admission more than 3 days, and readmission to hospital with puerperium, consider thromboprophylaxis, meaning if patient discharged well, the risk upon discharge after delivery, low risk for VTE, so we didn't start. And then patient come back, readmit again because of maybe patient having maternal paralysia secondary to infected perineum, okay, infected episiotomy wound. So we need to reassess again, okay, to consider if the risk is higher score, then we need to consider prophylaxis then. Okay, for patient with identified bleeding risk, so the balance risk of bleeding and thrombosis should be discussed in consulting with a hematologist with expertise in thrombosis and bleeding in pregnancy. Okay, risk of VTE after cesarean section. All women who have cesarean section should consider thromboprophylaxis with low molecular weight for about 10 for death from pulmonary embolism. A woman delivered elective lower segment cesarean section actually had a double risk of postpartum VTE compared to normal vaginal delivery, and when risk of postpartum VTE after emergency is 2 times higher compared to elective cesarean section and 4 times higher after normal delivery. Okay, risk assessment should be performed in each woman every time during antenatal visit, okay, ward admission, following delivery, okay, and before discharge home after delivery, which is postpartum. Okay, arrangement made for low fluid prescription and administration means we, according to the risk assessment score, according to based on patient, high risk patient, we need require VTE thromboprophylaxis to continue for up 6 weeks postpartum, and intermediate risk about 10 days. Okay, when woman is receiving antenatal fluids since the first trimester for any other reasons, for any type of reason, okay, when patient come into labor, so we need to advise to admit dose of long fluid once patient had sign and symptom of labor begins, and we should avoid, okay, if possible, until more than 12 hours after the previous prophylaxis dose. Okay, meaning if let's say patient already on a low fluid heparin since first trimester, so having symptom of labor, then we advise to stop, to omit the medication, the dose. And patient had means patient already in labor, okay, might need to push for cesarean section or patient request for epidural. So we need to consider the last, we need to know exactly the last dose of a low fluid heparin. So because at least the safety we can offer her for regional techniques such as epidural, spinal or what, at least the cap is 12 hours. If patient may require cesarean section, maybe NS should decide for a general anesthesia compared to spinal anesthesia, because the last dose of long fluid. And a low fluid should not be given for 4 hours after use of spinal anesthesia. Means usually after given spinal or epidural, to start the dose of levoglobate is more than 6 hours. Okay, and then if patient on epidural, we plan to remove the epidural catheter. We need to check the dose, at least the gap is more than 12 hours. Okay, this one is a prophylaxis dose. Okay, if the therapeutic dose, so we need to avoid at least possible for at least for 24 hours after the last dose. Means once patients on therapeutic dose, so already in labor, maybe in labor. So but the last dose is less than 24 hours. So the NS may decide to give to decide for anesthetic route, maybe for general anesthesia. Okay, and women receiving antenatal levoglobate having an elective disease should receive a thromboprophylactic dose. Means on the day of prior to delivery, means at least we omit for 1 day and then we start the levoglobate more after 6 hours post spinal or epidural. Okay. So this is anti-embolic embolism stocking. Okay, we can prescribe to the patient to prevent the venous thromboembolism. So the use of properly applied of appropriate size and provide graduated compression with cuff pressure of 14 to 15 millimeter mercury is recommended in pregnancy. And we have a different size. We need to measure the cuff length of the patient to suit which size patient need. Okay. Other prophylaxis is levoglobate heparin. Okay. The agent of levoglobate heparin is agent of choice for antenatal and postnatal prophylaxis, and those to start is based on body weight. And for thromboprophylaxis, the booking of most recent weight can be used to guide the dose, and it is only necessary to monitor the platelet. Means when we start levoglobate, usually unnecessary to monitor the platelet count and not required to monitor anti-10A level. And in a patient having renal impairment, so the dose may require the lower dose of levoglobate. And this levoglobate heparin is safe in breastfeeding. Okay, this is a example of levoglobate heparin. So usually we have enoxaparin, means glycine, okay, fragmin and inoheb. So usually in our hospital we have heparin and enoxaparin glycine. Heparin is unfractionated heparin, glycine is levoglobate. So we start the prophylaxis dose according to patient body weight. Okay, and usually the prophylaxis dose is daily dose. Okay. But we need to be cautious and we need to exclude contraindication before using levoglobate heparin. We need to consider any bleeding. We need to rule out any bleeding tendencies such as hemophilia, von Willebrand disease, or acquired coagulopathy, or we need to reassess whether the patient had any antenatal or postpartum bleeding. Okay, we also need to consider if patient having a high risk of major hemorrhage, like in a placenta previa, okay, thrombocytopenia, okay, acute stroke in previous 4 weeks, okay, whether hemorrhagic or ischemic, and in patient with severe renal disease or severe liver disease or uncontrolled hypertension, if the blood pressure more than 200, systolic and diastolic is more than 120. Okay, this is unfractionated heparin. So in women at very high risk of thrombosis, UFH may be used peripartum in preference to low hemoglobin, where there is increased risk of hemorrhage or where regional anesthetic techniques may be required. So UFH is used after cesarean section. However, we need to monitor the platelet count, not as low hemoglobin. We no need to worry about monitoring. So, and however, the benefit of UFH is short half-life and it can easier or completely reverse by protamine sulfate. And the required interval between the prophylactic dose of UFH and regional anesthesia or anesthesia is less than 4 hours compared to low hemoglobin is 12 hours. Okay, this is the benefit of UFH. Okay, this is the dose. Usually we give BD dose. Okay, about 5,000. Usually postpartum we use 5,000 IU BD. Okay, other alternative to reduce to prevent VTE we can use as a VTE prophylaxis is fondaparinux, erythra. Although the study is not a lot done in pregnant lady, but it still can be used alternatively are needed for pregnant women with heparin intolerance. Means that woman is allergic to, maybe allergic or she easily got a side effect if started the heparin. Okay, so typical reason for changing from heparin to alternatives such as fondaparinux, which is erythra, include allergic reaction and injection site, generalized rashes, heparin-induced thrombocytopenia, and also increased liver enzyme related to heparin treatment. Okay, warfarin. Warfarin is used in pregnancy. It is restricted in a few situations because heparin is considered unsuitable. Means if the pregnancy is uncomplicated or uneventful, so we consider low hemoglobin heparin. But in a woman having a complicated with a mechanical heart valve, usually we combine management with a medical and physician or cardiologist to properly manage. Okay, we want to prevent for the thrombosis and also we balance with the risk of this case woman that we might consider warfarin. However, in the rest we don't consider because of the risk of increased risk of congenital abnormality, including warfarin embryopathy, and also a risk of bleeding. Okay. And for this special patient, like a woman with mechanical heart valve, usually we can the physician will do breathing regime, means receiving long-term anticoagulation with warfarin can be converted from low hemoglobin heparin, convert back to warfarin postpartumly when the risk of hemorrhage is reduced, maybe after 7 days delivery. But this one, in this case, special case, we co-manage with cardiologists and medical for the further management. Okay, aspirin actually is not recommended for thromboprophylaxis in obstetric patient, and overall, any benefit of aspirin in VTE prevention appear uncertain and significantly less than the hemoglobin heparin. Usually we use in pregnancy to prevent preeclampsia, and also we prevent fetal growth restriction. Okay, and sometimes we can give for the patient with recurrent miscarriage, but aspirin itself is not a treatment as a thromboprophylaxis medication. Okay, this is a when we say that venous thromboembolism means usually patient will be patient can be present with DVT, deep vein thrombosis, and also pulmonary embolism. Okay, during antenatal checkup, we also need to be assessing or to get history from patient and proper assessing, especially over the lower leg of the patient. If you see asymmetrical leg swelling, okay, patient having pain or erythema and also dilated superficial vein, may suggest you need to think of deep vein thrombosis, because in pregnant is DVT is higher, so you need to properly check. If patient already having DVT, we need to start therapeutic dose of venous thromboembolism. Okay, this is a pulmonary embolism pathophysiology. So Birchall's diet, hypercoagulability state, okay, can cause the deep venous thrombosis, and when patient having a deep DVT, so it can lead to pulmonary embolism. So patient will be presented with hypocap, means patient will be presented with tachycardia, okay, shortness of breath, okay, and can lead to the V-PQ mismatch. Okay, so can also lead to sign and symptom of heart failure. Okay. So pulmonary embolism, if patient complain symptom of dyspnea, palpitation, and sometimes pleuritic chest pain, hemoptysis, and cough, so you need to think of pulmonary embolism, especially with when you do a risk assessment, that patient's score is high with this symptom. So the probable provisional diagnosis is you must think of pulmonary embolism and refer to us earlier. Okay, sometimes you can take for granted when patient complain to you with shortness of breath, palpitation for already a few days, then you didn't check properly, then you will miss the big complication of venous thromboembolism and can cause mortality, maternal mortality. Okay, this is when you want to roll out for venous thromboembolism. Usually you will do blood test, okay, baseline blood test, okay, and you can do ECG, okay, ECG in pregnancy and puerperium. So usually ECG was abnormal in 41% of women with acute pulmonary embolism. Okay, the ECG will show you at lead 1 is S1, okay, Q3 and T3 pattern. This one is classical for pulmonary embolism, and also chest X-ray is usually normal in over half of pregnant lady, and abnormal features caused by pulmonary abnormal. You can get abnormal features if that woman already had a pulmonary embolism, such as atelectasis, effusion, focal opacity, regional oligemia, or pulmonary edema. Okay, this is a chest X-ray. So sign of Westermarck sign. Okay, you can see the dilatations of the pulmonary arteries proximal to the emboli, and collapse of the distal vasculature, creating appearance of sharp cuff on the chest radiography. Okay, so you can see collapsing of the vessel. Okay, what is the role of D-dimer in acute VTE in pregnancy? Okay, D-dimer actually is a fibrin degradation product that can be detected in elevated level in blood when acute thrombosis occur. It's used as a diagnostic tool, but in a pregnancy, usually it remains controversial because in pregnancy, progressively rise D-dimer level with advancing gestational in multiple pregnancy and sometimes and abnormal at term. Jadi can be D-dimer, can be abnormal at term gestation. Okay. So we can perform also ultrasound Doppler of lower limb, okay, to check for the DVT. Okay, the sensitivity of serial compression ultrasound with ultrasound Doppler imaging was 94.1%. The negative predictive value was 99.5. Okay. If you suspect the DVT, you can send for ultrasound Doppler, okay? And also if the iliac vein is the pelvic side, if the higher side is emboli or thrombose, iliac vein thrombosis is suspected. You can see the back and the buttock pain. Patient may complain of back pain and buttock pain or swelling entire of the limb. So by this is the Doppler ultrasound of the iliac vein and also the MRI. You can also send for, you can request also for the magnetic resonance venography. This is the deep vein thrombosis pathology while doing the ultrasound Doppler. So you can see this is the clot, the direct visualization of the clot inside the vein. And then if you do the compressing test, you can see the vein is non-compressible because the clot is inside. Okay, and then if you augmentation with the color Doppler, you can see better, clearer. Other imaging modalities you can send for CTPA and also V-per-Q scan, okay, to get proper diagnosis of pulmonary embolism, the exact locations of embolism, the site and the size for further action, for further management. So, however, a few imaging modalities, there is other side effect or risk. Which can say that you can although the risk, the side effect and risk, other risk factor from the CTPA or V-per-Q scan, the main concern for the fetus is a very small increased risk of childhood cancer. And also, however, the CTPA is associated with low risk radiation to the fetus. Means it can cause relatively high radiation dose to the mother's breast tissue, which is associated with increased risk of breast cancer later. Okay, because breast tissue is especially sensitive to radiation exposure during pregnancy because of the hormonally induced increased glandular activity. The breast doses associated with CTPA can be reduced by 20 to 40% by the use of bismuth shield placed over the breast. Okay. So this is the algorithm for investigate an initial management in a suspected pulmonary embolism in pregnancy and puerperium. Okay, if you suspected pulmonary embolism, so you do like clinical assessment, you perform baseline investigation, blood investigation, you can do chest x-ray, ECG, and you commence straight away low molecular weight heparin. Okay, while waiting for while you investigating to confirm the diagnosis. And if there's sign and symptom of DVT, so you can perform, we can proceed perform ultrasound Doppler, and then if suggestive ultrasound Doppler, you just continue the therapeutic dose of molecular weight heparin. If we perform if there's no symptom of DVT, then you perform chest X-ray is normal. then you can perform VPQ scan. Or if there's no sign and symptom of DVT and the chest X-ray is abnormal, you get a suspicious finding, and then we can send patient for CTPA to confirm PE. And if CTPA confirm pulmonary embolism, so we continue therapeutic doses of low-molecular heparin. Okay, so any woman with signs and symptoms suggestive of VTE, so we should have objective testing performed expeditiously and treatment with low molecular weight heparin given until the diagnosis is excluded. Okay, and if DVT remains untreated, because if DVT remains untreated, 54% of this patient will develop pulmonary embolism. And pulmonary embolism during pregnancy may be fatal in almost 15% of patients and 6. So the management of VTE, confirmed VTE, treatment with therapeutic doses of low molecular weight should be continued until delivery and minimum 6 weeks postnatal and until 3 months of treatment has been completed. Okay, why we use low molecular weight heparin? Because more effective compared to unfractionated and less hemorrhagic complication, low mortality rate, and less risk of HIT, means heparin-induced thrombocytopenia. And this is a comparison between the unfractionated heparin and low molecular weight heparin. And yes, algorithm management suspected acute pulmonary embolism in pregnant lady. Okay, if you suspect acute pulmonary embolism in pregnant lady, we can do the dimer, okay, and assess the presence of 3 years criteria. Means number 1 is clinical sign of DVT. I check the rolling, any swelling, any pain, any inflammations, or ask any sign or symptom of hemoptysis, and pulmonary embolism are the most likely diagnosis. Then we check if the D-dimer, although the D-dimer it's remain controversial, but in years algorithm they still use D-dimer as a guide. If D-dimer is less than 1000 nanogram per ml and patient doesn't have yes criteria, so already exclude, there's no pulmonary embolism. However, if the D-dimer is high, more than 1000 nanogram per ml, we perform the CTPA, and if positive, we continue the therapeutic dose of low molecular weight. And if the D-dimer is low, but presence of 1 to 3 out of the yes criteria, so that one we withhold. It means if 1 out of 3 criteria with a low D-dimer less than 500 nanogram, so we withhold anticoagulant, means it's unlikely pulmonary embolism. And if the one it fulfill 1 out of 3 criteria with a high D-dimer more than 500, we perform CTPA, and then if positive, then we continue the therapeutic dose of low molecular weight heparin. And this is the role of IVC filter, inferior vena cava filter, have a role in the prevention of lethal pulmonary embolism when anticoagulation is contraindication to the patient, or we start the anticoagulant but unsuccessful, or we can use in pregnant women with acute thrombus around the time of birth, during intrapartum or near peripartum, can be considered for IVC filter if delivery is anticipated before clot organization. So I think the most important thing is a risk assessment during antenatal, and please get proper history, previous history, venous VTE risk or previous VTE history, family history, and thrombophilia history, or the current comorbid of the patient, which we need to screen, and the latest current patient condition, and calculate, and we try to score to get the proper scoring, and we can classify the risk assessment whether this patient is high risk, intermediate risk, or low risk. If patient is high risk, just start low molecular weight till patient pregnant, as till patient delivery for up to 6 weeks. If intermediate risk, then we start we consider start first trimester until delivery. If the patient is intermediate but the scoring is about 3 only, 3, so we start at 28 weeks of gestation until delivery. If low risk, we just advise patient for acute hydration, actively mobile mobilization, and the most, I think the most important also, postpartum. We need to reassess properly before allow patient to discharge home to prevent the venous thromboembolism. So by this slide, I end of my presentation. Thank you.
Thank you, Ma'am Azima. I have one question, ma'am. Ma'am, just now explain about the role of IVC, kan, ma'am? Do we
Yes,
so if the patient near to term and then we plan for delivery, but patient is already confirmed DVT, do we and also and already on a therapeutic dose of low molecular weight heparin. So do we still need to consider the IVC, ma'am, or we can proceed with the delivery without the IVC?
Okay, to answer your question, I think if patient already on like the indication of IVC is if the anticoagulant is unsuccessful, so I think because you said the patient already on low molecular weight therapeutic dose of thromboprophylaxis dose of low molecular weight, but still unsuccessful. Patient still having complication with pulmonary embolism. So I think for this, it need to consider IVC in view of after properly assessed, because you may need information regarding the thrombus, whether the thrombus is big or multiple thrombus. You use the size of thrombus and the site of thrombus, so that one all you get the information for the further action, whether it's suitable for IVC or not. It's not like simply for IVC, but we also need for discussion, and after get proper information regarding the thrombosis, the pulmonary embolism thrombosis.
Okay, ma'am. Ma'am, another question, last question. If it's confirmed a PE or DVT, then we start patient on therapeutic dose. So how long we continue this therapeutic dose? Is it 6 weeks postpartum or need to go for 3 to 6 months? Then we have to do back the imaging to see the clots again, or how, ma'am, in pregnancy and postpartum?
Okay, usually if already patient had thromboembolism, so we as ONG usually we can continue 6 weeks to 3 months, and then to reassess back patient's condition and patient symptom, patient condition, whether we need to continue to 6 months or not. Sometimes we need other physician input.
Okay, ma'am.
Answer your question?
Yes, ma'am. Thank you so much for today's presentation and for the Q&A session, ma'am.
Okay, thank you.
Okay, thank you, ma'am. Okay. Thank you for everyone to still stay tuned with us. So due to we are running late, I think we just take a short intermission while waiting for our next presenter. So we skip the break for now. So just stay tuned. We'll be right back. Thank you. We are moving on to our last topic today. The topic is from the only bee among the flowers. It means, so today's topic, the last topic is about mental health issue during and after pregnancy by Lieutenant Colonel Dr. Farid. He's our psychiatrist who's currently in Hospital Angkatan Tentera Tuanku Mizan. Let's welcome Lieutenant Colonel Dr. Farid.
Right. Okay, thank you, Dr. Sanghari, Major Dr. Sanghari, for the kind of introduction. So, good afternoon and Assalamualaikum to everybody, especially MOs. So today I'm going to talk about mental health issues during and after pregnancy. So, okay. The first thing is when women are pregnant is how the woman or mother respond to the pregnancy. I'm going to talk about psychological changes in pregnancy initially. So when the woman pregnant, usually they have some sort of feeling of grief. The grief is not a negative grief, it's just a loss. Loss means that loss of your normal, happy-go-lucky person, and no responsibility, and then your usual life. That's a grief during that time. And also some of the mother can have some mood swing. Is a normal psychological changes. Mood swing means that being influenced by some hormonal changes can affect the mood swing. And sometimes some of the lady might have suddenly crying, cannot control the emotions. It can be normal response during the pregnancy. And also changes in sexual desire. During the first trimester, usually the libido is low because of the what we call that the vomiting, and then because of hormonal changes initially, and then they will increase. The libido usually increase in second trimester because of the increased blood flow to the pelvic muscle during this trimester and the third trimester. The third trimester usually is depends because of the growing uterus and also finding the comfortable position during that. Sometimes the partner did not understand, and then they misunderstood lah about the spouse, his spouse punya what you call that situation, can lead to some kind of argument, and then the stress. These are major changes in life. So it's not only woman is involved, the husband. So the couple need to embrace the changes during the pregnancy, especially the first pregnancy, right? Okay, then, all right. These are for the tasks usually in the pregnancy. So during the first trimester, the woman sometimes need to learn about the pregnancy and accept the pregnancy. During this time, usually the pregnant lady somehow, during this time, the patient, the lady comes somehow ambivalent about the pregnancy. This first trimester is very crucial, whether they want to terminate or accept the pregnancy, what they're feeling about the pregnancy, especially the first pregnancy or the unwanted, sometimes the unwanted pregnancy. All right. So the second trimester, normally the couple already accepting the baby. So during that time, they will do some role play or dreaming about how the roles of the parents lah during this time. Okay. So the third trimester, usually the couple, the woman try to prepare to have the baby. During this time, usually they will buy clothes, dreaming about the baby, who want to take care of the baby when delivered. All right. So in summary, the pregnancy actually a big transition for the woman, from the start of the pregnancy and also to the end of the pregnancy lah. And not only woman, the people surrounding her, especially the husband and the family, the children, and also the in-laws maybe, right? Okay. So we talk about prenatal mental risk. So during the pregnancy is a crucial period, is a very vulnerable period for women getting the mental illness lah. So there is a risk of onset, a new disease lah, onset of serious mental illness. For example, depressive illness and also postpartum psychosis. And then for the women that have or already have the mental illness, for example, bipolar or depression, might recur and might relapse, especially the serious one. And also the recurrence might deteriorate the woman with the serious illness lah, for example, schizophrenia. Okay, and then risk of non-psychotic condition, especially depressive illness and anxiety, is during pregnancy, and also we not forget about the following delivery. Delivery is very important following delivery. So they also the risk is high during the following delivery. Okay. Right. This is one of the prenatal mental risk. Mental health risk. So actually the incident dengan prevalence of mild to moderate depression and anxiety is similar during pregnancy and also the postpartum period. Tapi there is increase in incident in the severe non-psychotic depression, especially early weeks following delivery. During the postpartum, immediate after delivery, we need to observe the woman, especially during that time, there is a increased risk to having the severe non-psychotic, means that depressive illness lah. Right. Okay, these are rates of prenatal psychiatric disorder per 1,000 maternities. If we see this table, which is shown that the adjustment disorder and distress is more compared to the other illness, adjustment disorders and distress such as postpartum blues is about 150 to 300 compared to depressive MDD or anxiety states, for example, generalized anxiety disorder. The postpartum psychosis, the PTSD, PTSD also is quite high, 30, but the postpartum psychosis is very rare, occur in the prenatal period. Okay, so the impact of prenatal mental health problems, if untreated, it will interfere with the parenting and also motherhood for the woman, and also it will interfere with the care of the baby and also the other children of the woman. It is a short term. In the long term, it will affect the maternal self-esteem. They will feel they are failure or bad mother. Not only her, it affect also the partner relationship with the husband, and also the family relationship, the whole. And also, it's not affect the family; it also affect the child. The mental health of the child and also the social adjustment of the child, and also will affect the until the adult time of the child, right? So the high prevalence, you see that illness in the prenatal mental health condition usually is a postnatal depression. Is a depression, not the postpartum psychosis or other serious mental illness. Usually, serious mental illness such as bipolar, schizophrenia, they already have the treatment. So they already have the treatment, so they rarely relapse unless the psychiatrists or the attending doctors modify the medication. All right. So we go to the antenatal depression. The rates actually range between 15 to 25. Some of the risk factor is a lack of education, young age, poverty, poor social support, and also unplanned pregnancy. Okay, all right. Then, so 2/3 of the women having depression will have relapse. Usually after they discontinue anti-depression. And the depression, the antenatal depression is associated with low weight, IUGR, and also preterm delivery, and is related to the symptom of depression because of loss of appetite, feeling hopeless. Then they don't take much nutrition for the baby fetus. All right, these are theme of the antenatal depression. Some women feel like negativity towards pregnancy. They don't want the pregnancy. Pregnancy is bad, and the thought of regarding termination of pregnancy. And then some of the women worry about the cost and outcome of the pregnancy. Maybe there's something wrong with the baby. Then they worry much. And then there's a question that they will ask: will I have a miscarriage? Will the baby be healthy? We're not sure. Some of them feel not able to cope with labor. There's many things that contribute to this theme. I will be a bad mother. Relationship difficulties. This is not only a woman. There's other things that affect the theme of the depression. Right? For example, the problem with the husband, or early experience of childhood that can affect how the mother thinking of the pregnancy. Then we go to postnatal depression. So the postnatal depression occur during childbirth, after childbirth. So it can be gradual or sudden, and it can up to 1 year. Yeah, it is spectrum from the mild, moderate, severe, and then of course it will affect the fathers and also the children. Okay. All right. The clinical presentation of the postnatal depression, usually having changes in sleep, anger, irritability, change in appetite, and also anxiety. Anxiety usually is very prominent in the pregnant woman because a lot of things they are thinking. So usually the theme in a postnatal depression is a low self-esteem, bad mother. It's a simple thing such as they fail to breastfeed the baby. They think, oh, I'm a bad mother. I cannot breastfeed my baby. I'm a failure. And also difficulty with the childcare, unable to please the baby, to pacify the baby when the baby crying. And then some of them extreme anxiety about health of the baby. They make them have a problem in sleeping because of severe anxiety. Hence, and some of them having overvalued idea, odd ideas or maybe cultural idea for them. Some of them having a severe panic attack because of the intractable, what you call that, worry, that lead to depressive symptom, and then eventually will lead to the suicidal thought. And sometimes having infanticidal thought, you want to kill the baby. And this will have a relationship problem with the husband and the family, and conflict within them. So this magnitude feeling after the birth. Most of the women will feelings what you call that, not persistent, sometimes tearful sadness, about 80 to 90%. Some of them develop depression, what you call that, postnatal depression. All right, and then very rare having a psychosis. Psychosis, of course, they will have the hallucination. But this is very rare, psychosis. So in Malaysia, postnatal depression is ranged between 6.8 to 30.7. It depends on the questionnaire that you diagnose the PND. Usually they use a Edinburgh postnatal depression scale. I think the ONGs are familiar with this EDPS. Right. So some of risk factors of developed postnatal depression is because of other factors. Negative life event occur before the delivery. For example, previous birth complication, or some of them having loss of employment of the partner. They're worried about the financial status, how they're raising their family. And also comorbid illness, for example, health difficulty. All right, and then stress mainly area how to care the baby, the infant care. Some babies have a difficult temperament, and some of them very stressful to the parents to cope with the area of infant care, and also some of the women don't have the support from the husband to take care of the baby. They're alone, they think. Another factor is poor marital relationship. Maybe the husband is not cooperative, or there is some conflict with the relationship, maybe extramarital conflicts or what. And also, I think quite common in a woman-mother relationship, usually with the mothers-in-law, the mothers commented on how his daughter taking care their grandchild and children. All right. So these some of the things of the marital dissatisfaction. So because of the woman perceive husband not support practical emotion, and then but the husband is a kind of high control, always dominant, and not even care about the wife. Some of husbands sometimes jealous with the baby because the wife give more attention to the baby compared with him. All right. All right. The another risk factors is poor family support. That I say before, the women are alone. They need to take the woman need to taking care their children, the other childrens, and also live at home alone. And then there is no support from the family and also from the husband. And then there's a risk factor, and the patient having the anxiety or depression during the course of the pregnancy. There's a risk they develop a postnatal depression after the delivery. And of course, the genetic factor, for example, if they have a family history of postnatal depressions or previous history of having postnatal depression of previous pregnancy. What they call that, kalau kita tanya dalam history itu, history of meroyan. In Malaysia, meroyan encompass all these things. Depression, psychotic, all we call it meroyan. All right. So there's another story. So for the early experience risk factors. Early experience means that difficult relationship with the mother before. Sometimes it reflects after their delivered baby, and also when there is a history of sexual abuse. All right. Okay, another factor that important is infant temperament. Mothers or babies who cry more likely depressed. And then this another things in the way they got depressed mother perceive infant yang cry ini more perceive infant more demanding. All right. So another risk factor is the woman attitude, personality. For example, low self-esteem, poor social skill and child-rearing skill. Personality factors, for example, the type A personality means that is very perfectionist, need to control everything. There's high expectation. That's the thing can contribute to the depression if the things that they expected they did not get what they expected. All right, and then cognitive style, how the woman thinking, the cognitive schema of the thinking, such as believe that they have no control over event or they can control over all event in life, right? Okay, this thing is can contribute to the postnatal depression. All right, some of the social what do you call aspect of motherhood. For example, you can have your serenity after your childbirth. All right, and then unrealistic expectation. These some of the expectation may cause frustration, and then may cause may lead to sense of failure for this thing. So actually, the truth of motherhood is a complex. Is a transition period in the life. There is a huge physical, emotional changes in life, and there's also physical stress. For example, we need the woman need to breastfeeding the baby, and then need to taking care of demand of the baby, and then sometimes they need to change their lifestyle. So they need totally change, and then it will lead to the frustration unable to do their usual activity. All right. So I'm not sure at the start we have you need to screen all the what you call that if you suspect especially having depression. So it's not easy being a mother. So we see that 1 of 10 women feel depressed after giving birth. The good thing, depression is a treatable. So if you miss to treat the depression, is very sad for us. So usually screening, we do the Edinburgh postnatal depression scale. Is a known internationally been translated. I think it's been translated in Malay version. They cut off about 11 or 12 for the cases. So they found that during the validation study, 6 out of 10 women who score positive on EDPS will meet diagnostic criteria for MDD. Some of them having minor depression, adjustment, or postnatal distress. So means that it's quite good for the screening purposes. If you don't have EDPS, you can use also DAS or what, no problem. Because this is only a screening. If they score high screening, just refer the patient. Because we don't want this happen to the mother. Well, I said before, there's will affect not only the mother, but also the what you call that the child, the family, and the whole family of the woman, right? Okay, we talk about postpartum blues. Postpartum blues is a mild form of depressive symptoms. It's very transient and is self-limited. No need medication for the postpartum blues. They need only the reassurance and also the support from the family. Is common things. It's more than 50% occur first few weeks after delivery. All right. So the risk, as I told before, the risk of postpartum depression is high in patient with baby blues that have a mood symptom, mean depressive or anxiety symptom during the pregnancy period. So we need to watch out for that. So if you suspect the patient have postpartum blues, you need to screen for any suicidal ideation or any paranoia, paranoid, or any thought, not the psychotic, the flare of psychotic, mean any pre-psychotic thought, or any suicidal or homicidal ideation towards the infant. So we come to the psychosis. So there's a few types of psychosis in prenatal period. So the chronic one, schizophrenia, okay, I think you all know. So the woman has schizophrenia before the pregnancy, right? This is a chronic one. The acute one is organic psychosis. It is actually rare. So usually organic psychosis, for example, if the patient having encephalitis, during the pregnancy or after postpartum, and also what you call the affective puerperal psychosis, new incidence or new occurrence of the psychosis. This is an acute one. So we talk about postpartum psychosis. The incident is 1 to 2 per 1,000 delivery. It can occur acute, immediate after delivery, or up to a month. Right, these are some of risk factors: past history of postpartum psychosis, family history of postpartum psychosis, and there's thought that people with the bipolar disorder is a propensity to develop a postpartum psychosis, and also postpartum psychosis. If there is the woman develop postpartum psychosis, can develop bipolar disorder in the future. That's the thought. So there's sometimes we cannot differentiate between the mood symptom and psychotic symptom. Sometimes the patient with the postpartum psychosis having a mood symptom, for example, low mood, lability. Sometimes you cannot understand what they say, rambling speech. On top of that, they also have the delusion, jealous delusion, grandiose delusion, and also hallucination. And sometimes they are confused. That's why usually we need to exclude all the organicity before we come to this diagnosis. If the woman first presenting with this illness. So the risk of out of 1,000 women with the postpartum psychosis is 2 of them will have complete suicide. The suicide in the pregnant lady or in a postpartum lady can be violent method lah. For example, jumping from height, and also self-incineration. Self-incineration, self-immolation means that they burn themselves. That can be very lethal. So they are likely to express the homicidal ideation. So when they express the homicidal ideation or their suicide ideation, you need to refer to the psychiatrist lah, during your follow-up. However, they rarely express the homicidal behavior. That's very tricky. So I want to touch about breastfeeding and mental health. Actually, breastfeeding is very important factor for the mothers having a good mental health. Because if the mother some of mother fail feeding his baby, they feel that they are failure. They are not a good mother that cannot what they call the breastfeed the baby. Sometimes there's a culture also. If you are a good mother, you need to breastfeed the baby. Sometimes it's difficult to tell. All right. So there is some psychological benefit of breastfeeding, because when the mother breastfed the baby, they will reduce the stress level of the mother by lower the mother's inflammation level. Some of theory stress, depressed because of inflammation, high inflammation level. But the breastfeeding can lower the mother's inflammation levels. Hence, we reduce the stress. And then mothers that breastfed the baby can fall asleep easier, and then the much more quality sleep longer and more deeply sleep. And there is a increase in oxytocin level. Oxytocin level is a hormone that can make people more relaxed, more calm, right? And lastly, because of when your mother breastfed the baby, then can enhance the physical and emotional bonding of the baby with the skin to skin contact. All right, that's all for my brief lecture of the mental illness during and after pregnancy. Okay, back to the we call that Sanggari, moderator.
Thank you, Dr. Farid. We have few questions here. The first one is from Lieutenant Colonel Dr. Amirawati. What psychiatric condition, in what psychiatric condition termination of pregnancy is permitted in our Malaysian legal and healthcare setup?
All right. Yeah, this is a very complex question to answer. Of course, it's from the specialist, I think.
Yes, yes, sir.
So usually they're not there is no law actually for the termination of the pregnancy in Malaysia. Usually, if the condition really what they call that jeopardize the carrying of the baby, and also what they call that the mother. That will come to the decision, but the decision the usually is not from the one side. You need to do some what they call that multidisciplinary approach. Means that semester meeting, usually we take psychiatrists, ONGs, or pediatrician to have a meeting regarding termination of the pregnancy of the patient. We need to weigh benefit and also what they call that the risk, because it's not easy. You want to terminate the pregnancy, right?
Okay, sir.
Okay.
The next question is how many fathers do develop postnatal depression? Do fathers really develop postnatal depression too? Is this percentage similar as women? And how they manifest the symptoms for the fathers? How sir?
All right. Honestly, I don't really counter with the fathers with depression postnatally, but there is a case of postnatal depression affect the fathers, because they cannot cope with the caring of the children. Many of the fathers many of the men develop what we call the anxiety more because of their caring of the child. They feel worried. Okay, for example, giving a milk to the baby. Is it okay, doctor, giving me the baby, or they will cough when I give a milk to the baby. So there is not really much studies on the what you call that postnatal depression in the father. Maybe we can do that. Okay, but
sir.
there.
Okay, so it is the genes, sir.
Yes,
but probably
because you know a man is a creature that don't want to look weak. They don't express their emotion. Especially, of course, they want to see a psychiatrist. They don't want to see a psychiatrist, so they keep to himself.
Okay.
So that's a difficult thing for the postnatal depression of the father. Okay, all right.
Okay. So you got a lot of questions. I hope you don't mind.
Okay.
So just now sir has mentioned that 1 in 10 women can develop postpartum depression. So in our PERPAT research setting, as a primary care doctor, do we need to do the assessment for every woman who keen to conceive? It means a pre-conceptional counseling. During that time, do we need to assess the mental health of those women?
Yes, if it is good if you can do that, but I'm not sure about your workload, because some of the constraint of the workload. If you can do that, yes, it's good. You can screen for that. Sometimes woman is not ready. The father yang beria-ia nak dapatkan anak, kan? That's the thing that can lead to the frustration bila dah pregnant semua tu, kan? Then they ask for the termination after that. Yes, you can do that, no problem. So, if you have time.
Which tool that you recommend the primary care doctor to use for the assessment, sir?
All right. The best tool is your clinical judgment, your clinical tools. You can use DAS, no problem. If you don't have, when patient pregnant, you can use Edinburgh postnatal depression scale. That's also no problem for that.
Okay. One more question. I mean, we have 2 more questions. So the next one is, what are the consequences of patient has a bipolar disorder and anxiety attack if she get pregnant? What about the medication? Do they need to stop their medication or they just can continue their medication, sir?
All right. Okay. That management leave to the psychiatrist. No lah. Okay.
Okay,
So
sir.
basically, we weigh risk and benefit for the patient. There's a certain medication that we are what we call that harm to the fetus. For example, lithium, epilim, right? So if the patient means that remission with that medication, usually, and then we discuss with the patient whether they are agreed to withhold the medication or reduce the medication. Then we need to collaborate with the ONG to regular frequent follow-up, for example, for the detailed scan of the baby, and then we psychiatrists usually will we call that psycho-educate and also tell the risk to the fetus regarding all the medication. And some of the patient want to stop, but there is a risk of relapse. That's we need to tell the patient. And if the relapse is so acute, the patient might need ECT, electroconvulsive therapy, for the bad relapse. Usually we don't totally off the medication. We simpan sikit the medication for them to survive the pregnancy. Okay, all right.
Yes, sir. So I mean, ECT you can do in pregnancy?
Yes, especially is very suicidal, because ECT is a safe method, safe way, because we give the anesthetic to the lady, and then we just they don't have much feed. The brain will feed, but the body is not fitting.
Oh,
Okay.
I also just know that ECT is actually can give
Yes.
pregnant, sir.
There's one indication, ECT, pregnant lady with
Okay,
high
sir.
suicidal.
Okay, I have the last question, sir. It's in BM. Bagaimana cara yang boleh Tuan cadangkan untuk menghadapi isteri mengandung yang klaim akan mengalami tekanan emosi atau kesukaran tidur semasa ketiadaan suami? I think this happens a lot in our services where the husband go for the operational minimum 3 months, some being away from the wife for, if you go for missions, about 1 year, sir. So how do women?
Yes. Yeah, it's a common in our setting. There's the role of bakat. Bakat and also unit. Unit to take care the family when the soldiers going to the operation. Unit kena tanya, okey ke tak nak pergi, ada sakit ke. Sometimes that things, and kalau ada barang ke nak beli, duty officer kena tanya the family, macam mana keadaan. Tapi kalau dia dah menyebabkan ada depressive symptom, you need to refer. And also bakat lah. Bakat means that kena buat aktiviti untuk para isteri ni. Sometimes I personally I nampak bakat macam tak buat apa-apalah lagi pasal isu-isu macam ni kan. So you need to do that. Untuk occupy masa tu, distract isteri itu daripada rindu kepada suami. Sometimes suami pun pandai, dia will manipulate. Isteri saya mengandung, saya tak boleh pergi operasi, so it's not good. Okay, unit and barisan belakang and also bakat. Usually kena ambil take this thing lah. Take these things serious, and then they need to monitor dekat unit berapa ramai perempuan yang isteri yang anggota yang mengandung. So kita kena tengok anak-anak isteri dengan anak-anak ni kan, apa yang perlu antenatal follow up, especially kalau kena bawa ke hospital, bawalah. Sometimes I know, sometimes kekangan anggota, all those things. And also boleh juga family, mak ke saudara boleh duduk bersama isteri. sementara suami pergi operasi. Sometimes operasi tu tak ada line telefon, itu yang paling susah tu kan. Kalau yang ada line telefon, you need to video call every day your wife, isteri, untuk tanya khabar semua, untuk lepaskan rindu. Okay. Kalau tak ada video call pun bolehlah berutus surat ke kan, macam dulu kan. Alright.
Okay, sir. I think in this case, if patient, if swami want to go for operasi or missions, maybe contraception will be another option. It's just contraception. Maybe our primary care doctors should counsel regarding the contraception when they will know the particular husband need to go for missions and everything, sir.
Yes,
I think
agreed.
Mental health, I think it's about everyone needs to give a proper support for the woman to go through the whole pregnancy. From Sir's speech, I think that's what I can make a conclusion. It's everybody plays a role. Am I right, sir?
Yes. Not only women.
Yes, sir. Okay, I think
right.
we finished with our questions for you, sir. I think we got the most questions for today. Okay,
PM personally, DM personally.
Yes, anyone who I think if still have more questions, please feel free for PM Dr. Farid personally. And thank you so much, Dr. Farid, to spend your time for us today.
Okay.
Okay, thank you, sir.
Right. Okay.
Ladies and gentlemen, finally we come to the end for today's webinar. We would like to thank again to all our presenters today for their very interesting and informative talk. And thank you to all the audience for your active participation. Hopefully today's webinar gives a beneficial talk for everyone. So we will see you tomorrow with more interesting topics, with another 4 interesting topics by Colonel Dr. Shazni and Lieutenant Colonel Dr. Amira. The webinar for tomorrow will start at 8:25. Please be before that time. And it was a pleasure being with you today. Thank you so much, everyone.